Interest in such an engaging subject, and I know we're here to try to find solutions and deal with some of our healthcare challenges. I wanted to take the opportunity to inform many of my constituents here what we are currently facing in our community and some of the challenges that will be brought up, I'm sure, in this evening's discussion. And although I'm the MLA and I probably know what's going on at the O'Leary Hospital more than many, I still don't consider myself an expert. I'm not a clinician or a healthcare professional, and I'm sure Dr. Wedge or Minister Curry can correct any issues. But I want to take the opportunity to explain what we have currently, what some of the challenges that we are facing in O'Leary, and to talk about some of the solutions that our government is proposing and how they may help alleviate and correct that. So currently in Western PEI, we have a complement of 12 physicians, of which 11 are practicing at the moment. I guess there's one physician that's on paternity leave as well. And they're practicing family medicine in this region. 4 are currently practicing in the O'Leary area, 2 are at the Guardian Drug location, and 2 are based out of the O'Leary Health Centre, and 1 vacancy exists currently. The new modern health center that's attached to the community hospital provides various services including diabetes clinics, mental health, addiction services, provides 6-day per week walk-in clinical services, and space for family doctors, among other services. At the health center, our challenges currently, it is underutilized as a space and only has 2 doctors practicing at that location currently, and with one vacancy, plus 1 nurse practitioner vacancy. The current 2 physicians have chosen to provide support to Western Hospital, providing 1 24-hour shift per week at the emergency room in Alberton. Every hour they provide there comes off their office hours in O'Leary. This provides tremendous inconsistency in our walk-in services. The Margaret Stewart Ellis long-term care facility is attached to the community hospital and provides space for 40 long-term care residents. Recently, a new 15-bed extension has been added to the previous section and has been renovated, with 8 beds added to be opened currently. And I'll leave the remainder of those beds to Minister Curry when he speaks. And we're going through as we just recently gone through a transition for those remaining beds that have been put in service. This is probably the most up-to-date of all our public long-term care facilities in the province. Community Hospital in O'Leary provides 13 acute care beds, providing convalescent, restorative, and palliative care. We have probably the most modern palliative care section in the province, and they provide services for non-life-threatening patients. We have X-ray, lab services are provided to support the facility. Inpatient support and admissions are provided under the care of a physician. Physiotherapy, nutritional, home care supports, and other services are provided. The entire facility is heated by a modern biomass heating system, making it one of the most cost-effective buildings to heat in the province. Existing challenges at the long-term care patients are awaiting placement and are using beds better utilized for extended care, and the need for more occupational services for inpatients, and the need to upgrade our lab and X-ray equipment as it is becoming outdated. This equipment is provided by the Hospital Foundation. Ambulance services exist for 2 ambulances in a depot located at Willow Avenue, and O'Leary has very well-trained professional paramedics. On the wellness side, we also have first-class recreational facilities with the community, including a rink, curling rink, ball fields, walking tracks, racetrack, and many Go PEI programs, among others. To address the above challenges, the creation of the CEC model of paramedics providing nighttime support at Western will free up a minimum of 24 hours per week of physician access to clinical services in O'Leary. And Dr. Wedge believes that with some creative scheduling, we may be able to provide more than that. With the addition of the new long-term care beds in O'Leary and the newly designed 13 beds in O'Leary, will be providing now a term of alternate or extended care, providing the same services as before: convalescent, restorative, and palliative care. There will also be a rebalancing of the physio and additional occupational therapy services to better address the needs of admitting patients. Lab and X-ray will remain and may get greater use as Tyne Valley's X-rays may be coming to the end of its life expectancy. Also, under the model, it should be easier to fundraise for such equipment. If we have new modern equipment, better supports for the clinic, it should be easier to recruit that vacant doctor and nurse practitioner position. Also, as part of a greater 4-ambulance system within West Prince, the addition of a rapid response vehicle will provide additional support to volunteer first responders and our current paramedics. Telehealth will also be an asset to those wondering where best to access services. In a perfect world, we would have to say that everything would stay the same. We would never have to implement change, but perfection is a very hard thing to achieve. If only we wouldn't have to comply with standards, rules, regulations, building codes. Doctors work the way they used to work long times ago, 80 hours a week or more in lots of cases. But those older generation doctors just don't exist anymore. Physicians, like other professions, they want a better life-work balance than we have in the past. We must respect this. The residency program that our government has initiated has been helpful as it has attracted one physician to our community, and the Office of Recruitment and Retention has been successful in providing 2 other physicians here since I've been elected. But the newer pool of physicians choose not to provide emergency room services for a multitude of reasons. I wouldn't get into all that right now, but so, in general terms, I think we should be grateful for the physicians that we do have in our community. One, local individual from our community has established a practice here, and it shows under the right situations we can attract physicians to rural communities like O'Leary. Minister Curry and I, we've worked hard. We've met with our hospital foundations, and I want to recognize Eva Rogerson, the chair of our hospital foundation here. We've met with many professionals and residents alike. I've personally had the opportunity to discuss these challenges we are facing with healthcare, with many of my constituents and healthcare professionals, both within Health PEI and with those that are providing the care to our community and our facilities. Yes, and I have had a variety of opinions and suggestions, but I tend to choose to speak and listen to some of our newer professionals. And yes, even experienced ones too, like Dr. Charles and others. I've had the opportunity to talk with individuals, some of the paramedics. I see Whitney Harris here, Grant Hardy. My own daughter's an RN, and I've talked lots with other recently trained professionals, LPNs and RCWs. These are the best and brightest of our community. They are people who are telling me that a model like this has some chance of success if implemented properly. They're the ones that will give you a whole new perspective on the evolving issues and trends in healthcare. I'm choosing to take their advice, as they best know their professions and how best to implement their full scopes of practice within their section of work for the betterment of the patient. So with that, I hope that we can have a good discussion here today. I look forward to hearing some solutions. I've been to a number of the other meetings. I find we seem to be short on solutions, lots on criticism, and I think I, as an MLA for the area, would readily admit the system that we're providing here in O'Leary is not to the standard I would like it to be. We need to have those issues that provide that better access to our physician. And I believe this model will not necessarily solve every problem. I don't think healthcare will ever be perfect. It's always going to have its challenges. It's always going to have its stories. But I think this process and this model that we are proposing here tonight, and I'm sure Minister Curry and some of the staff here will give you more detail on that, will put us well in the direction of solving some of those problems and make it as good as it can possibly be. So with that, I'll introduce a colleague of mine, a man I have a great respect for. He had a lot of questions today in the legislature. He's had a lot of questions all last week in the legislature. But I can honestly say that Minister Doug Curry has the best interest of Islanders, their health care. We are dealing with huge challenges out there. We're dealing with aging demographics, issues that are going to always, and it's probably only going to get worse when I see some of the briefings and some of the facts that are out there. And as much as sometimes we choose to not look at those facts, I'm sure Minister Curry does look at it in a serious manner, and we'll do our very best to try to provide the best possible access, because you, the constituents of O'Leary Inverness, I'm always concerned about your health and well-being. So with that, I'd like to introduce Minister Doug Curry, and then after that, the moderator, Carol Cabana, is here to chair the meeting. Thank you very much.
Well, thank you very much, Minister Henderson, and certainly you're fortunate here in O'Leary, Inverness, to have an MLA like Rob. He's very engaged, not only in his own responsibilities as a minister, but also very engaged in the issues around healthcare. And certainly, of all my caucus colleagues, he would be certainly as knowledgeable as anyone in respect to the issues in healthcare, not only in the community, but he also shares a passion and a vision for making sure that we have good quality, sustainable services. So with that being said, I'd certainly like to acknowledge there's a number of MLAs and ministers here in the audience tonight. Certainly would like to acknowledge all the board members from Health PEI, obviously the staff from Health PEI, but most importantly the residents that live here in the community of O'Leary and use this community for healthcare services when the need arises. So obviously this is the fifth meeting that I've attended, hosted, sort of partnered in respect to across the province over the last few weeks. And certainly an opportunity for us to share good information, respond to questions, address any concerns, but also talk a little bit about healthcare and some of the realities and some of the pressures that provinces, not only here in Prince Edward Island, in communities across Prince Edward Island, but the realities and pressures that a lot in all jurisdictions across the country are experiencing. So obviously there's two big issues that are working against us, whether for lack of better descriptors. We've got in relation to the Chief Public Health Officer's report, we've got clear indications that we've got high volumes of chronic disease that we're trying to manage in Charlottetown and in communities all across Prince Edward Island. We also have a population that is aging. We've got 1 in 5 Islanders will be turning 65 by the time 2020 arrives. We have a window of baby boomers that are between the age of 50 and 70 that are moving through our system. And if you look at what government has done over the last 10 years, government spending on healthcare has doubled. When we came into government in 2007, the provincial budget on healthcare was approximately $360 million. Today, we will be moving in towards $570 million. So the challenge for us is how do we continue to provide appropriate care, protect our acute care beds for our most sick Islanders. Today, we would have 200 medical beds, which we would identify as acute beds, and approximately 80 of those 200 beds are being used and tied up with non-acute patients. So we're seeing long wait times in emergency rooms. We're seeing challenges and cancellations for elective surgeries. So as healthcare evolves, and I know that in this part of the province, like the eastern part of the province, 30 years ago, we were delivering babies and performing surgeries here in facilities. Healthcare has evolved and will continue to evolve moving forward. Governments, current and past, were faced with tough decisions, and that discussion is presented at all of the community meetings. But government's responsibility is to make sure that we have services for Islanders in the appropriate situation, at the appropriate time, at the appropriate location. Currently today, we've got 5 community hospitals. We've got 2 major referral hospitals, the QEH and the Prince County Hospital. We also have a provincial addiction facility, and we also have a provincial acute mental health hospital as well here in our province. We also have a out-of-province healthcare budget, which is the second largest hospital we have here, but it's located outside the province, and that's approximately a $50 million budget. So when Islanders need healthcare services, whether it be vascular, whether it be cardiac care, whether it be a range of different services that are offered and aren't offered, maybe were offered at one time at the QEH, but are currently not offered. So that budget is approximately $50 million here in the province. So as I've said in communities, I see us as Islanders with a population of 146,000 to be very fortunate to have what we have. And I also see opportunities as we continue to look to the future to make sure that we're meeting the needs of Islanders, that we're providing services in communities, but also that whether you're a constituent or a resident of West Prince, that we're going to make sure that if you need acute services at the Prince County Hospital, timely emergency room services, and acute beds, whether it be at the Prince County Hospital or the Queen Elizabeth Hospital, or if it's at a province, that the system will be there for you. So what we're looking at moving forward is a system that is very integrated, that relies on each facility to play a very, very important role. And we continue to hear in communities the discussion around the community hospital budget is $22 million. Well, that is correct. The community hospital budget is $22 million, but also as part of the community hospital budget in primary health care, there's other services that are wrapped around community hospitals, like public health, mental health and addictions, a range of services which provides a provincial budget of about $81 million. And that's not counting physician salaries. That's not counting services at the Prince County Hospital that people in this region access. It's not counting services that you receive at the QEH, and it's not counting in services that you may require if you're required to go to the VG in Halifax. So basically my responsibility as minister is to look at healthcare equity across the province in a very, very challenging time with pressures that are in front of us. Certainly over the last 6 years, we've invested over $200 million additional operational spending in healthcare. We have ramped up the number of physicians we have in the province. We've increased physician spending and salaries from $62 million to $105 million. And we've got more nurses, more LPNs, more RCWs than we ever have. And we're still having challenges in respect to access to good quality emergency room services in timely fashion, access to family physicians, which is a real issue here in this community as a result of physicians being drawn out to other areas of the region to provide services. We have long wait times for elective surgeries as a result of our inability to provide acute care beds in our main two referral hospitals because Islanders can't access a bed. Islanders are driving to Charlottetown only to be told that their surgery is canceled because there's no beds available. And right now today, out of all the beds in the province, we have a high volume of beds that are not being occupied. So the model that we're presenting is using our facilities to their full potential and accessing those beds to make sure that the beds are being used to support. For example, if an Islander, if my mother goes into the QEH for a hip or a knee or some service, that they will be admitted to the surgery. They will be spending 2 days at the QEH for approximately 2 days. And this model will be communicated that they'll spend the last few days of their post-op recovery in a facility outside of Charlottetown. And that message has been very clear, whether it's in the media. That message was very clear when I spoke in Charlottetown. And we have to use all our assets to their full potential. If we're going to continue to respond and maintain good quality healthcare services in this province, every facility is going to have to play a key role in doing that. And whether you're living in Borden or Stanley Bridge or Alberton, Tignish, Tyne Valley, Surrey, Charlottetown, everyone deserves the right to have an equitable quality level of access to services throughout the province. And that's the challenge, and this is the realities of what we're moving to accomplishing here. We've made substantial investments in long-term care. We've ramped up in the number of long-term care beds since coming into government. I believe now we're approximately 170 new long-term care beds, trying to meet the demands. We have a wait list of approximately 150 currently waiting for long-term care placement in this province. We've doubled our home care budget. We've almost doubled our primary health care budget. So we are spending money in health care, but we have to continue to find ways to use all our facilities. And as I use the expression, everything has to be moving on 4 cylinders all the time, and everything has to be used. And we have to make sure that we're not wasting any of our assets to protect those real emergency services and those high-end acute care beds that you may need. It could be your mother, it could be a family member, but the system has to be there. And healthcare has evolved. It will continue to evolve long after I'm gone. and these changes will continue to prepare our system to meet the pressures that we're facing. So with that, I want to thank you for coming tonight. Certainly, we've got a format, some presentations, and then we'll open it up for questions. So thank you very much.
Thanks very much, Minister. As Minister Henderson said, I'm Carol Gabana, and I'm the moderator for the meeting this evening, and it's lovely to see you all on such a beautiful spring evening, I hope. I want to tell you just what's going to happen for the rest of the evening. There will be presentations by Dr. Richard Wedge, who's the interim CEO of Health PEI. There will be a presentation by Matt Crosman, who's the general manager of Island EMS, and then one by Marnie McCrae, who's the manager of recruitment and retention, and she'll be talking about physician recruitment and retention. And following those presentations, which aren't that long, there will be time for questions. And the plan is that we'll be finished here by 9 o'clock. So I ask you now to welcome Dr. Richard Wedge.
Thank you very much. So I'm going to go through a few slides. I see a few familiar faces in the audience that people have seen some of these before, but this is really sort of keyed for the folks in the O'Leary area. Just want to summarize sort of where things are going here in O'Leary. That the plan is to convert the O'Leary Hospital into a specialized extended care hospital. So they will provide extended care services. The lab and the x-ray services are going to remain here in O'Leary and available to people on a regular basis, similar to now. There will be a new rapid response unit that Mr. Crosman will explain in further detail in a minute. There's going to be some access to enhanced primary care services that we'll go through. The ambulatory care services are going to remain in O'Leary as well. And these are ambulatory care things like scheduled wound care dressings, putting casts on, taking casts off, some blood transfusions, IV antibiotics, that sort of scheduled things that occur now in the O'Leary Hospital are going to continue to occur in the O'Leary Hospital. The walk-in clinic service has been a very irregular service. It's actually very poorly run over the last 3 or 4 months because we just don't have the staff. And the plan is for that to continue once we stabilize the situation in Alberton. The 811 telehealth system will be another system we'll go through in a minute. And then, as the Minister says, an additional 15 beds have been built onto the Margaret Stewart Ellis wing at the O'Leary Hospital. 8 of them are currently staffed now, and 7 more are going to be staffed over the next couple of months. So that adds another 7 beds to the West Prince area. So in terms of primary care, right now in the West Prince Primary Care Network, we have added a number of medical appointments, obviously going in to see physicians in their office, as has been traditionally here for the last 30 or 40 years. There's been a number of new services added over the last few years, including various chronic disease management with advanced care nurses and some of our the general RNs that are in the practice as well. They're not all advanced care, but some of them are diabetic educators. So clinics for diabetes, high blood pressure, chronic lung disease, people that are on blood thinners, warfarin, that kind of thing. There's special clinics available now in O'Leary that weren't here before. There's also well child visits being done by public health, well women clinics that are done on a rotating basis as well, and the provincial PAP clinic is here on a regular basis. So the walk-in clinic is limited, as we were saying, because of the availability of physicians and the vacancy, as Minister Henderson pointed out. In terms of acute care, there's been a lot of confusion around this term, and what we're using in the healthcare system around acute care is really our sickest islanders, as the Minister said, and the people who need access to round-the-clock nursing care, some heart monitoring, people who need intensive care, access to specialists on a regular basis. So those are the people we're talking about there. When it comes to extended care, we're looking at people who need restorative care. These are people that have mobility issues. They need another few weeks in the hospital to get up and down the stairs at home. They may have some problems with walkers or post-stroke and that kind of thing. So they do need some strengthening, and they do need some abilities to restore their activities of daily living. Convalescent care is generally people who are having prolonged problems after surgery. So as the Minister points out, people who have hip surgery, the vast majority of them actually end up going home within 2 or 3 days. But some of them end up with mobility problems, or they may have a post-operative infection, and they need to be in hospital longer. And that's convalescent care. Respite care is offered to families who are caring for some fairly sick individuals with a lot of chronic disease at home, and they're just either getting worn out, or they have healthcare issues themselves, or they just want to take some time off to be with themselves. They need a place to be able to put their family member in the hospital. Palliative care obviously is an end-of-life care that's also needed in hospital as well. There are a number of people who receive an in-home palliative care program here in West Prince as well, and that's going to continue. But some people don't want to die at home, or they may need some pain control medications in a hospital, and that's something that has been built up here in the O'Leary area for the last couple of years with Dr. Grimes. So I just want to point out that extended care is not long-term care. These are people who need the services of a hospital. They need the nurses, they need physiotherapy, they need occupational therapy, they need access to have their blood drawn, that kind of thing. So that's the reason why they're in a hospital and not in their own home. So just as a reminder of people of what are some of the other things that are happening across the province, Stewart Memorial will be converted into a 23-bed long-term care unit. Community Hospital O'Leary and Surrey Hospital will be equivalent as extended care hospitals. The Western Hospital and Kings County Memorial Hospital are going to continue to provide acute care, and the acute care is obviously in support of the fact they have an emergency room that needs acute care beds available to support those patients. And Prince County Hospital and Queen Elizabeth Hospital will continue to be our acute care centers with specialist care. We just added a slide in here. We had a couple of visitors on Tuesday from Ottawa, Dr. Kitts and Dr. Jeff Turnbull, who have come down to PEI to see what's going on. They've heard about some of the stuff that's in the news around how we're using our hospitals to be better utilized and fully utilized. So they have come down to have a look at what we're doing and talk with us. This is just a picture of the Ottawa Hospital. The Ottawa Hospital has around 1,200 physicians in it. They have 7,700 nurses. It's a $1 billion a year operation, and they have in their beds 130 patients who are needing alternate levels of care on any given day. So that's 130 people, and they have regularly 40 to 50 people in their emergency room waiting for care in the hospital. So they're looking at a number of hospitals just outside the Ottawa area. One of them being the Stittsville Hospital, and I'm not sure if anybody's familiar here, but Dr. Setti, who worked here for 35, 40 years in the Tignish area, has actually moved to Stittsville, and he would be familiar with that community hospital that's there. So they're looking at providing an extended care hospital similar to what we do here. And of course, to get into the Ottawa Hospital, they draw on about 4 or 5 hours in their local regional health authority in Ottawa. And the people drive for 4 or 5 hours to get into the Ottawa Hospital, but they pass a number of other hospitals on the way. So they're looking at a similar thing to what we've done. Yeah. So in terms of where people in West Prince are being admitted to the hospital now, you can see the large blue circle is the Prince County Hospital, where about 45% of the acute care patients are currently admitted now, today in Prince County. The red circle being the Queen Elizabeth Hospital, where obviously a number of people are transferred there, mainly for acute surgical things from this area. And then the green area being the Western Hospital. So if you add the blue, red, and green circles together, about 87% of West Prince residents are now being admitted to acute care in those 3 hospitals. The other 2 are, of course, the O'Leary Hospital and some in the Tyne Valley area, and very few in Kings County. This is a slide just to show, if you look on the last group there, I don't know if you can see that little red pointer, but the blue, there are about 11 or 12 patients every day in the Queen Elizabeth Hospital in the emergency room waiting for a bed, and about 2 or 3 people in Prince County every day waiting for a bed. This is a slide just to show the current utilization, the number of people that are alternate level of care in the red on a daily basis. And then this last group is the ones that are in West Prince. So there are people, of course, in both O'Leary and Western Hospital who are alternate level of care already. Just to talk a bit about the Western Hospital community, the Collaborative Emergency Centre, during the day from 8 to 8, the plan is that it'll continue as a full emergency room as it is now, with a physician and nurse available for those times. And then overnight, some other additional staff, whether they be a nurse or paramedic or 2 nurses. We haven't worked through that model with staff yet. But there will be 2 health professionals available to assess the patient. There will be an online medical control that they will phone and decide on the disposition of the patient, whether they go home treated or whether they go home, come back the next morning for treatment, or whether they're transferred to Prince County. The 811 telehealth system is one that we're going to partner with the province of Nova Scotia. It's currently up and running in Nova Scotia now, and it's basically a dialing an 811 on your phone, and you'll get free confidential health information that they will help you out with, and that sometimes you may be able to treat yourself at home or your family member at home, or you may be directed to see a family physician or some of the other services that are available, and things like mental health, diabetic education centers, that kind of thing in the community. The one advantage to this is it's going to be available 365 days of the year, and it's going to be available in multiple languages. So before I get into the examples, I do want to talk about the O'Leary Hospital and what's been going on over the last couple of years. As many would know, Dr. Grimes has pioneered this extended care hospital concept. He is the house physician currently in O'Leary, and it is now operating and has been for the last 2 years as what we would consider an extended care hospital. So he has set admission guidelines for the staff, for the nurses, and they have been operating this way for 2 years. So what people in the O'Leary area are going to notice is nothing, essentially, because it's already happened for the last few years. So I just want to kind of make sure if people are wondering about, well, I was admitted last week and I'm not going to be admitted anymore. If you were admitted last week, you're already meet the criteria for extended care hospital. So there's going to be very little change noticed amongst the people here in O'Leary. People may have some questions around that too when the time comes, and that's fine. So some of the examples we've been using are from emails that have been coming in or from phone calls. But for example, this 94-year-old lady from the Tyne Valley area that was brought to the emergency department and needed to be admitted, but there was no bed available. Rather than wait and emerge, they were taken home, and this occurred about 4 times over the next 4 months. And this is obviously not the way we want to care for people who are 94 years old and needing a hospital bed. And another one was an adult male who fell from a ladder and broke his upper arm and had to wait in a hospital, waited in a hospital here in the West Prince area for 5 days, waiting to be transferred to Queen Elizabeth Hospital because they didn't have any beds available on the orthopedic floor to treat this man. And it's obviously not something we want to see either. It's not a great care. So that's a kind of a list of the summary of things, and I'll turn it over to Mr. Crosman from Island EMS, and then we'll be available for questions after.
Thank you, Dr. Wedge and Minister Curry and attendees here tonight. As said, my name is Matt Crossman. I'm the General Manager for Island EMS, and I know Dr. Wedge said that a few of you have seen our presentation before, but I know there's some attendees tonight who haven't seen it. I'm just going to go over a few different things. We're going to talk about Island EMS, when Island EMS began, what it was like previous to Island EMS, and some of the new enhancements that we're going to introduce over the next coming months. We'll also have a question period at the end if any of you have any questions. And for some reason, if you don't have an opportunity to talk tonight, if at any time you'd like to ask us questions, you can always contact myself through our website or our information line. Previous to Island EMS, which was previous to April 2006, we had 5 ambulance operators on Prince Edward Island. They all did a great job in their respective communities and provided a quality of service. There were a number of benefits to amalgamating the service into one provincial service. For instance, previously, there were 5 previous operators. When one of those operators or one of those system vehicles would leave a community and travel to another area outside their jurisdiction, they weren't able to respond to calls. So if they did a transfer, let's say from O'Leary to Charlottetown, and they were coming back empty, and there was a call in Tyne Valley or Summerside, they weren't able to respond to those calls because it was outside their jurisdiction. The benefit to having a provincial system is all of the vehicles are utilized for the goodness of the residents of Prince Edward Island, and I'll talk a little bit about how we utilize that. Previous to 2006, there was no centralized medical dispatch center, so there were different ways that each service dispatched their medical calls, and we've been able to amalgamate that into one centralized service now, which I'll talk a little bit more in a couple seconds. There was also no centralized equipment, vehicle acquisition, things like that. There was really a variation of what level of service, what type of paramedics, what level of training, and what type of equipment each ambulance carried. So there wasn't a standardization or a process across the island where every community got the same type of care. So in 2006, Island EMS took over the provincial service. We implemented a bunch of additional resources. Currently today, we have a long-term service contract with the Government of Prince Edward Island. We have over 140 paramedics ranging in primary care, intermediate care, and advanced care levels. All of our units are staffed with advanced ALS paramedics. We have currently 19 units without any of the additions which have been recently announced, and one of them consists of a multi-patient unit where we can transport 2 patients at the same time. Some of the benefits which we've been able to implement over the last few years is we have a standardized medical dispatch center. Not only is it a medical dispatch center, but Medicom Atlantic also provides the 911 service for Prince Edward Island. So when you place a call into 911, the call comes into one center. Within that center, we provide the ground emergency medical dispatch for the entire island, as well as 34 out of the 36 fire departments are dispatched out of that one location as well. So when one call comes into the center, all of the communication officers are able to hear that call, see that information, and they're able to dispatch those crews that much more quicker. That means we're able to get our crews responding to the emergency very quickly, in many cases, while they're still on the line with you. We've been able to standardize our ambulance fleet and equipment. If you get in any one of our units across the island in any location, they're all laid out in the exact same order. They all have the same amount of equipment, and our paramedics can provide the same level of care in every community. We've been able to standardize the scope of care in Prince Edward Island for all 3 levels, primary care, intermediate care, and advanced care. We've been able to expand that level of care so that the services we're providing here in Prince Edward Island really match those around the world. So we're very excited about some of the enhancements we've been able to bring, and the quality of training and the quality of care that our paramedics bring to Prince Edward Island. You'll notice at the back of the room we have some paramedics in attendance tonight, as most of you know from the communities. There are some pamphlets back there, and you can really get some good information about the level of care paramedics are able to deliver. And we'll also have an ambulance outside tonight for anybody that would like to talk to the paramedics, see inside of it, ask questions. And I encourage you, not only tonight, but at any time, if you have any questions, to either contact myself, the operations manager for the West, as most of you know, Claude Gavin, and or some of our paramedics if you have some general questions about what level of skill or what level of care. And there's also the Paramedic Association of Prince Edward Island that can answer some of those questions. I'm going to explain just a little bit about how we utilize our resources. As I said before, when the previous operators were here, and this was no fault of their own, but it wasn't a provincial service, so they had their designated areas where they could provide care. With a provincial service now, we're able to utilize vehicles all over the island. So what that means is if we had a rash of emergency calls in the O'Leary area, we're able to pull other resources from other areas to make sure that the area is covered. With these additions, which we're going to talk about in a little bit, we're very confident that it's going to improve our response times within this area and all communities across Prince Edward Island. We've worked very hard over the last couple of years to try and improve our response times, and we've really improved them over the last couple of years. When you look at the map up on the screen, you'll see a bunch of variation of boxes and different shadings and colors. These boxes are basically a summary, an annual summary of where all of our calls have taken place. We analyze this data on a daily, monthly, quarterly, and yearly basis, and it really does change in each community depending on different events. So as you can imagine, in the summertime, the Cavendish area sees an influx of individuals within the summer months. We're able to look at that data, analyze it, and try and anticipate when calls may take place. Another thing a lot of people may not realize is the majority of our calls happen in the daytime hours. We have a large clusteration, and we try and upstaff during those hours. That's why we have additional units on during daytime hours, is to kind of alleviate some of those pressures that we may have on the system. And we look at our data on a constant basis, looking at what time of day they happen. For instance, when some people go from one community to another to go to their workplace, you're more apt to have a higher call volume. So we try and anticipate those calls, and we try and put our resources in the right location. We have another program which I just showed a demonstration. We're able to capture where our vehicle is in a specific location, the amount of time that they'll be able to travel within a certain period of time. So we'll know when that vehicle's in that location, how long it's going to take to get to a certain call. So there's been some recent announcements with, as Dr. Wedge said and Minister Curry, we have 2 rapid response units which will be introduced in the next coming months. We have one in the eastern end of the province and one in the western end of the province. Particularly, this is going to benefit the rural communities. We're very excited about introducing these new enhancements. It really starts when the call comes into 911. We're able to get our resources responding to the scene, as I said, very quickly, and we're able to get to the scene and start to administer that advanced level of training. Paramedicine has grown a lot over the last couple of years, especially the last few decades, with the care that paramedics are now able to deliver in the field. We're recently starting to introduce where we're doing 12-lead ECG transmissions. We'll be responding to a resident's home, hooking that patient up to a cardiac monitor, doing a 12-lead ECG transmission, and sending it to either the Prince County Hospital or the Queen Elizabeth. And the physicians on call are able to read that before we even leave the scene. They're able to prep their teams, and they're able to get things ready so that if you are in need of thrombolytics or clot-busting agents, they're able to get them ready, and as soon as we arrive at the facility, administer those type of medications. In the coming time, we'll also be able to look at possibly administering those types of medications. Our paramedics are well trained for that. This 12-lead ECG transmission is something that would help allow for us to do that with the physician reviewing it. So we're very excited about where we're progressing. Online medical control is a very valuable piece of information that we utilize on a daily basis, have for the last couple of years. Our paramedics are in constant connection with a physician who's able to get a clear picture of what that paramedic's seeing, that patient condition, and we're able to adjust our treatment to benefit the patient. We do 100% call audit of all of our medical calls in Prince Edward Island. That means we review every patient care record. We look for ways to improve, and we try and make sure that we're giving the best possible care to island residents and looking for ways to improve patient outcome. This is just a quick overview of what paramedics are able to deliver. One of the things that we've really moved from is being able to administer specific medications and move to it being able to administer classes of medication. This allows us to do a lot more advancements, even on routine transfers or emergency transfers in between hospitals. As Minister Curry said, we transport a lot of patients off island to either New Brunswick or Nova Scotia, and our paramedics are able to carry some of these medications, which allows the nursing staff to stay back in the facilities where they're really needed, and it really allows us to reduce the amount of staff that are required to go off island. Some of the things that we're really looking to do is obviously improve our response times in all the communities. Every vehicle or every type of unit we add in the system helps alleviate those system pressures. And we're really looking to utilize our data and make sure that our vehicles are located in the right area. These rapid response unit will be an integrated part of our system status plan, which is, as I said before, utilization of our vehicles in all communities. So as vehicles respond to calls, they're going to be able to treat patients. Some of the questions that have come up before is if the rapid response unit responds, how long until an ambulance is there? As the rapid response unit responds, an ambulance will be dispatched as well. The difference is typically today when an ambulance responds, they treat a patient, they have to transport the patient, and they're not available until they arrive at the facility, transfer care to the nursing staff and physician, and then become available. The great thing with this rapid response unit is they're going to be able to respond very quickly to the scene, administer a high level of care, another ambulance is going to arrive, they're going to transfer the care over, and a few seconds later, they're back in service and ready to respond again. So that resource isn't leaving the community. It's still available for the next call. We found that a lot of our data shows that a lot of calls happen in sequential order, so we'll have a couple of calls very quickly, and that can sometimes lead to delayed responses. So this is going to really improve our response times. We're very excited about being able to deliver this in both the east and west end of the province. The next unit is the ambulance transfer unit, and a lot of you probably don't realize, but a third of our call volume on Prince Edward Island equates to non-emergency transports. We have a large volume of calls where we transport patients from facility to facility for routine tests, different appointments, things like that. With the introduction of the ambulance transfer unit, we're going to be able to get the resources to the appointments and be able to take the patients where they're supposed to be. What we utilize now are our emergency ambulances, and a lot of the times we'll have our day schedule out with 4 or 5 transfers, but because of an emergency call, we become delayed on 1 or 2 of the primary calls, which then equates to a delay throughout the day. So with the introduction of an ambulance transfer unit outside of our system status plan that won't respond to emergencies, we're able to schedule these appointments and we're able to meet the timelines, which not only alleviates the pressure on the patient, most importantly, but also the facilities, not only sending but receiving, and our paramedics as well. It really does equate to a lot of stress within the system. You can imagine if you've been waiting for an ultrasound or an appointment to see a specialist for a period of months, and all of a sudden, because of an emergency such as a car accident, now we're not able to meet that appointment time. And it can be very frustrating to everybody involved in the system. So we're very excited about the advancement of this vehicle. This vehicle will be wheelchair accessible. It'll also be stretcher accessible, and we're very excited to have this introduced over the next few months. Thank you very much for your time, and look forward to questions at the end.
Good evening. I'm Marnie McCrae. I'm manager of the Recruitment and Retention Secretariat with Department of Health and Wellness. I've been working in the role with recruitment for the past 3.5 years. And in this role, we have lots of challenges. A couple of the areas that we've found to be quite challenging have been in some of our specialty areas, oncology, physiatry, but also in recruitment in our rural communities. But we're not alone in that. I know the rest of the country and my other counterparts across the country are dealing with those same types of challenges. So in the West Prince Health Network, just to give you a bit of overview on some of the efforts in this area, we do have, as Minister Henderson said, we have 12 physicians in the complement, and we have 1 vacancy currently. We have 1 nurse practitioner vacancy as well. We work with, our physician recruitment coordinator works with all of those interested candidates that come forward from our efforts. And when they review the applications, we're looking for those that are licensable, those that have a good background and are a good fit. And we're reviewing all our vacancies across the province with those folks. So currently, rural vacancy-wise, we have 2 vacancies in Surrey. We have 1 in Montague, and we have the 1 in West Prince. We're doing very well in Summerside. We don't have any vacancies currently. And in the Charlottetown area, we're also looking really good right now. So our big focus has been in our rural areas. Just to give you a sense of some of the site visits, I don't think I'm too loud here, some of the site visits to the West Prince region. Over the past 10 years, we've had 33 site visits to this community at a cost of approximately $3,000 per site visit, so about a $99,000 investment in this community for site visits with physicians. When we bring folks to the communities, we're bringing along, if they have a spouse or partner, we're bringing them along so they get a sense of the communities. We're taking them to the facilities, they're meeting with the physicians, they're meeting with the managers, they're touring the community, and if they have children, we're making sure we connect them with the schools in the area. We're connecting them with real estate as well, so they know what's available, what the community, we're really lucky here because a lot of people look to PEI and say, ooh, the cost of living here, this is great. So that's always a plus for us. So we make sure they learn all about the incentives when they're here for the visit. Often they'll come and they'll visit more than one site when they come to PEI. So they may be coming to Surrey, and they may be also coming to Montague, and they may be coming to West Prince, or they may just choose one site. But generally, they're coming to more than one site when they come to the province. We've had approximately 28 over the last 8 years locums to your community. So your locums may be providing a week of service, or they may be providing a number of months. And one thing that's been a real benefit to this area is that you have some locums that like to come back on a regular basis and provide some service to you that's really valuable to your community. We have had some challenges, as you do in each area in the province, when it comes to recruitment. And when we talk about, the rural physician recruitment, it can be a challenge. Some of the areas that we found in West Prince, we've heard from some who have made the decision to leave that they found the workload to be heavy. They found the ER department coverage at Western, along with the full patient load and walk-in clinics, to be a significant workload for our folks. So that's where, if we're going the route of the new collaborative emergency center, I think from a recruitment perspective, it's going to benefit us. I think we're going to have folks who, that new young physician that's just coming out is going to say, you know what, this is a better work-life balance for me. Minister Henderson talked about the work-life balance. That's really important to these candidates today. Some of our new residents, too, when they're coming out, just getting started, their preference is to get some clinical experience under the belt before they're ready to work on those solo ER coverage. So that's what they're telling us. The PEI residency training program, which no doubt you've all heard of, but we've been very fortunate in PEI to have our own training program here, which we're connected with Dalhousie. And the graduates from that program are getting to work in our island communities in their last 2 years of their training before they start working as practitioners. And we've seen last year all of them decide to stay in PEI, and that's huge. That's huge. And 2 of them, Dr. Burley for one, and also we had one of the other ones choose Montague. So they are starting to choose some of our rural communities as well. We decided we wanted to look at what we can do for our rural communities, and is there an enhanced incentive we can provide. So in the past 3 months, we put out to those new residents who are coming out from PEI an opportunity for those who would have an interest to practice in either Surrey or West Prince. So we looked at our 2 areas of greatest need from a rural community perspective. And we said, we will provide you with a $50,000 signing bonus if you decide to stay. They didn't decide to stay and take us up on one of those offers. Some of those are deciding on the Charlottetown area. They're getting signed off now, but they haven't all been finalized as yet, but we have 3 currently signed on for Charlottetown. But that was a great opportunity for them, and they took it, they considered it, but we're disappointed they didn't choose it. We also have the new Family Medicine Sponsorship Program, which you may have heard about. We have applications out now. we heard from students who said to us, it's costing so much to go to school, and can you not provide us with support while we're in our training? So that's what this program's all about. In their second year of training, they can sign on, and the applications are open now. And we're focusing on the area of greatest need. So for those people who choose to sign on, we're looking for 3 candidates. We're giving a preference to islanders. And if they choose to sign on, they're going to receive incentives that amount to $110,000 between now and the end of their training. And at the end of the training, we're going to find the area of greatest need in the province for them to practice in. So that's what they're signing on for. So we're hoping it's not going to be here, that they'll all be filled by then, but if not, we do have an opportunity coming up in our future. And this is some planning that we really need to do. And they have a 5-year commitment to stay within that region in that same area. So I just want to quickly review, because I know you're all ready for questions, but quickly review our ongoing efforts. So for the West Prince region, we have a recruitment committee, and we meet by teleconference every 2 weeks. And that committee includes our primary care folks, it includes our health center folks, the Western Hospital administrators, and our recruitment staff. And we meet, we talk about any candidates that have come forward, we review locums, we talk about where we are with ER shifts and what the challenges are right now with shifts. We send out on every couple of months, once we get a list of those shifts that we know aren't covered, if we don't have a locum available at that time, we send that out to every physician who works in ER across the province, along with those who are family physicians who have ER certification, and seek urgent support to fill those shifts at the ER department. The advertisements that we've done just recently, just for Canadian doctors, the Medical Post magazine, the Canadian Medical Association Journal, the Canadian MD website. This is all for rural physicians specifically. These have just gone out in the last month. We're attending a job fair next month, which is focused on primary care in Toronto. We'll have a booth there. 2,400 physicians, 600 NPs are expected to be in attendance. So we'll be recruiting actively at that event. Our competitive incentives, as all the rest of the country competes for rural physicians, so do we. And we have an excellent incentive package on a regular basis that's very competitive with the rest of the country. $35,000 return in service for 3 years commitment, and $10,000 to $20,000 towards moving expenses when they relocate to the province, depending on where they're coming from. The application closing is coming up for our new sponsorship program I talked about, May 15th, so we're crossing our fingers on some good candidates. And just one last thing as I close, the Retention and Integration Committee for Health, the RICH Committee. Work is starting in your end of the province as well. This program started in Summerside, it's gone down east, and now it's coming up west. Newcomers Association received funding from Health Canada to look at what we can do for health professionals by bringing together the community, by bringing together the school system, by bringing together health professionals and saying we need your help. We want to integrate folks when we do recruit them so we can retain them. We want their families to feel integrated and part of the community. So if any of you folks are interested in being part of that, it's rolling up here and they've just started some committee meetings. The Newcomers Association would love to have your support. So one other thing that I hadn't mentioned is that we do provide support under Dr. Wedge's division, under Medical Affairs for Memorial, for the students at $800,000 a year. And that's to have seats in the medical school there for Islanders. So those are some of the incentives, some of the things we're involved with from recruitment. So I'll hand it back over to the moderator. Thank you.
Thanks, Marnie. And so now it's time for you to ask questions. And all of the folks that are up here at the front, plus additional staff from Health PEI, are available to answer questions that you have here this evening. And the plan, as I said earlier, is that we would be done by 9 o'clock. You'll see that there's a mic just behind Minister Henderson there beside Minister Sheridan. And I would invite you to come to the mic to ask your question. And if you would please say your name so we know who you are. And if you are unable to come to the mic, then I have a portable mic here and I'll come to you. So you just need to wave your hand and I'll do that. I wasn't watching and the room was filling up as I was sitting up front here, and so we have quite a crew of people. This is the fourth session that I've been at, and I do facilitate a lot of meetings, and so what I know is that people are passionate about this topic tonight. And I'm going to suggest that because we're in O'Leary, and I know that there are folks from interested folks from other communities as well, that maybe the folks from O'Leary might want to be the first ones to speak tonight, and just so we make sure that everyone gets a turn. And so, yeah, I invite questions at the mic.
Helen McNeil from West Devon, O'Leary area, and I'd like to ask Ms. McCrae what the qualifications are for the doctors and to please explain them for foreign doctors and this 1 to 2 year experience. I'd like this explained and so that we know why it's reading like it does. In some places it had read there were exceptions for UK, USA, South Africa, and Australia. But up here it read 1 to 2 years experience. I called Pat Murphy and he had that straightened out. But now it just reads 1 to 2 years experience. So what about these UK guys? Do they still have to write the exams or not?
Can you speak to the requirements? Dr. Wedge would be good to speak to the requirements.
At one time in PEI, and going back a number of years, physicians who are trained in various Commonwealth medical schools did have preference in Canada. But that changed several years ago, that we no longer we have to treat everybody equal around the world. So no matter where they train around the world, their medical training has to be considered the same. So basically what happens is you can't discriminate against non-Commonwealth country members. So that law changed in Canada several years ago. As to why it was on the website, I'm not sure, though. I think that's kind of your question. But the reality is any applicant has to be assessed on its own merits, no matter where in the world they've trained. Under PEI law, which is the same as any other province for the Medical Act, they have to be in a WHO, the World Health Organization, recognized medical school in order for the training to be recognized. So they have to be from a WHO school, and now they can be assessed in Canada. The 2 year experience is there, and I don't want to speak for the college because I realize there's a number of problems with the college, but the 2 years experience is there because we don't have a medical school to assess their training, where they do have medical schools in other provinces, where if they have an applicant that they feel is acceptable, they'll work alongside the medical school staff, assess their training, and then give them a license to practice either temporarily or under a mentorship program. We don't have a medical school here. That's the main problem. I'm not sure if did I completely answer your question, or? Okay.
Yeah. So just on the ad, we did have an error. That piece hadn't been taken off of the ad. So we revised the ad, and they're all consistent now as far as the qualifications go. Okay. But when candidates come forward, as I said earlier, we do review them with all of the various communities where there are vacancies. So if there was an error in it, which there was, we hadn't made that revision, then they would be looking at every application anyway, and we would have the college review all of their applications for those who meet them. Okay? Thank you.
I'm Eva Rogerson. I probably have 2 or 3 questions. I'll try and make them short. The one that I'm really pleased to hear you say that you're going to retain the lab and x-ray, because as the Health Foundation, we're getting ready to go to fundraise for our new equipment. So I'm really thankful for that. One question I want to ask, in the extended care, is there any one thing that'll be different than what we're doing now? For example, I know a friend, let's say they had a bladder infection and they had to go in just for some IV or whatever. Will that type of thing be able to happen? She was in before, so I'm just wondering, when you said, I know there's not going to be many changes, will they be able to do that type of thing?
Yeah, so the simple answer is yes, that will still continue to happen here in O'Leary. Now, if they have a bladder infection because they're diabetic and their diabetes is out of control and they've got heart disease or chest pain, that's not going to happen. But if it's a plain, simple bladder infection that's not responding to oral antibiotics and they need IV for a few days, that's going to happen.
That's going to happen. Thank you.
Yep.
And the other one, and I don't know who wants to answer it, is our clinic. That, and I know I've been sending lots of emails and keeping them well informed. But anyway, as early as today, I checked. There's no walk-in clinics in April, none scheduled for May. Our biggest challenge here has been access to primary health care. We can't get to the specialist. We can't get just to see a doctor. And I've tried every avenue. So I'm just wondering, and I know you've already given me some answers, if you could just share, is there any kind of a time frame when this is even going to improve the slightest?
Yeah, I do agree. Access to primary care in West Prince in general, O'Leary in particular, is not good right now. It hasn't been good for a few years, and that's one of the driving reasons as to why we're trying to make some change in the system. So what happens is we were explaining earlier in the slides is that 2 of the physicians from the O'Leary area are providing on-call emergency work in the Alberton Hospital. I don't know if I'm getting feedback here, whether you guys are noticing that or not. But because they work those 14-hour shifts on site, and then some of them stay on site because they don't live in the Alberton area. They have to stay in the hospital, but they're not quite sleeping because they get some calls during the night. They're not able to work the next day. So as Minister Henderson was saying, it takes away from their 37.5 hours in the clinic because it counts towards their time in emerge. They also take the next day off, so they're missing 2 days, not 1. Because they're working in emerge. So as a result of the change to the Western Hospital, the 2 physicians, one who does 8 shifts a month and one who does 4 shifts a month, there will be an additional 12 days a month that they will be back and in the clinic. And because they're in the clinic and they see about 25 people a day, that's about 300 appointments more a month that are going to occur in the O'Leary area as soon as the CEC model is up and running in Western Hospital. And of course, once the vacancy is filled in O'Leary as well, that's another 4,500 appointments a year that will be available. And then once the nurse practitioner is filled, it's another 4,500 appointments a year. So we're talking really about 12 to 13,000 appointments a year will be available in O'Leary when we can fix this problem. So the answer is sometime towards fall, we hope to have the CEC model up and running, is when we'll have that sort of immediate stopgap help. Once the nurse practitioner is filled, and I don't have a timeline for that, we're actually looking for 2 nurse practitioners for the West Prince area because the nurse practitioners are keen to work in a team. So we're going to be looking for 2. And then once the vacancy is filled, that's going to be the other advantage. So the big problem is when there's a sudden change and there's a physician heading to Western Hospital to try and fill a shift at the last minute, a lot of people are getting phone calls, and I'm sure there's people in this audience are getting phone calls saying their appointment is canceled. Sometimes it's the 2nd and 3rd times that appointment is canceled, and then they're finally able to get in a few months down the road, and that is not acceptable, really isn't.
No, that's probably been the most frustrating thing of all. No access at all. And I've tried for different people. I've tried every angle I knew. And the other question, and I know my family physician is one of those. 42 days was a normal wait for me to try and get to see him. But that man shared with me that he's tired of going 3 ways. And when I heard the recruiter saying this, he said, when my child is grown, I'm out of here. Nobody wants to carry that load. So if something doesn't change, we're not even going to have the ones we heard. That's what I've been told by my family physician.
Yep.
So that's a big concern. But on the recruitment, when I mentioned about some new physicians going to Charlottetown. I talked to a lady today that was up here to awake, and she told me longest wait time there is about 2 days. She's been down there a year. She has a family physician. I have a daughter, a granddaughter, that I've written letters all over the place. Still no access to a family physician.
Yeah.
So those are the areas that really concerns me. I'm glad to hear of the improvements in the ambulance service. But the rapid response, and I asked the question the other night in Tyne Valley, I have the understanding that that's only going to be available from 8 to 4. If that's not adequate, do you see 8 to 8? Sorry. I thought it was 8 to 4 or 5. Pardon?
9 hours a day, 5 days.
Okay.
9 hours for those who didn't hear at the back. Yeah.
5 days a week.
9 hours a day, 5 days a week. Yeah.
So that's how you're going to begin with the rapid response at those hours. Okay, because I misunderstood the other night then. I thought you said 8 to 4 or 5 is what you're looking at.
Thanks, Dr. Wedge. Thanks, ma'am, for the question. What we're looking for is Monday to Friday. We're looking about 9 hours a day. It could be fluctuating anywhere from 8 to 5, 8 to 4. It depends. What we're going to be looking at, and each community has a variation of when the calls take place. As I said before, we look at our statistics on a monthly, quarterly, and annual basis. We break it down per hour, per community, and where those calls take place. So, for instance, in the western area of the province, the majority of our calls could happen from 9 a.m. to 3 p.m. And in the eastern side of the province, it could happen from 11 a.m. till 7 p.m. So we will be adjusting those units based on when the majority of the calls take place in those communities. But on average, we're looking at 9 hours a day, 5 days a week. Our transfer unit will be 5 days a week, 12 hours a day, and that might have been where the confusion came in. And that'll really help with the majority of the transfers, as most of the bulk of our transfers happen between 8 a.m. and 6 p.m. So that's really going to alleviate a lot of the pressures. Within the communities, especially within the western side of the province, the additions last year to the ambulance service really helped. We added in a couple additional resources up west and also in Summerside, and it's really helped to alleviate some of the pressures. Remember, as I said before, it's now a provincial system, so when we do get busy here in the western end of the province, we now pull resources from the east. So if we have 3 units or 2 units in Charlottetown and we get busy in the west, we actually pull units from the east into the west. It's a provincial system now, and we utilize the resources across the province. We don't, maximize our resources to make sure Charlottetown and those areas are covered. We make sure that our entire province is covered. And our communications officers have really done a great job at watching those. We really think, remember, these are 3 additional resources into the system. That's quite an addition, and we really think that they're going to help with the overall improved response times, and the ability for those rapid responses to quickly free up is going to make sure that people get access to the primary care within their homes, which we're very excited about.
Okay, thank you.
Thank you.
Thank you.
I'm just going to complete the answer that for Ms. Rogerson around the long wait. I think you said 42 days or so to see your family doctor. That's a similar situation that actually occurred at Spring Hill. And when we were over to look at the CEC last summer, the Spring Hill Hospital, they had a hard time getting into the doctor because they were always working in emerge or taking time off because of the night. And that went from a 6-week wait to a 2-day wait. Some of the other projects that we're doing in primary care, just while we're waiting for the next person to come to the mic, I don't want to come on up, but then I'll stop. But we're doing a number of advanced access projects for family physicians here in the province. Dr. Grimes' new clinic at the Guardian Drugstore is one of those, where they're trying to see all their patients either the same day they call or the next day, and that's working out actually quite well. I don't know if he's here to kind of explain some of that, but we've done that at the Harbourside Centre as well, where they have close to 9,000 or 10,000 patients, and they have same-day access in Harbourside for all their patients. This is not walk-in patients, but for their patients. Dr. Stewart in Cornwall has done that for his patients. He has around 3,200 patients. They have same-day or next-day access, and that's quite an amazing thing that they used to actually line up at 6 o'clock in the morning for his 1 or 2 spots to the point where the police were called different times to clear the traffic. and now they have same-day access. So, no, sorry, come on up to the mic. And the other clinic that we've done some work on is in Montague with Dr. Scott Campbell, and he's a newer physician who had some trouble with his wait times as well, and he's gone to same-day access. So we're hoping to expand that, and once the O'Leary clinic is stabilized, we hope to expand that even further.
Good evening. My name is Bill Costin. I'm a retired high school teacher, having spent 35 years in the classroom, either in O'Leary or at West Isle. Along with my time in the classroom, I have volunteered with a great number of, well, a reasonable number of healthcare institutions. I spent 8 years as a member of the board of Prince County Hospital in Summerside. That board no longer exists. I spent a number of years on the board of O'Leary Community Hospital, which that board no longer exists. I stayed on with the foundation for a while. I spent 6 years as a member of the board of Prince County Addiction Services. That board no longer exists. I spent some time working on the committee for the proposed new West Prince Hospital, which blew up. I'm scared to speak here tonight in case something else disappears. You think they leave it for me, Rob? Mr. Minister, that is Mr. Minister Curry, I don't envy you your position. I know it's been a heavy, busy load. At any rate, I have just some random thoughts here that I want to leave with you. Not really questions, not really accusations, but just some comments with regard to healthcare. Over the last 5 decades, I have come to believe that there are those who make decisions which directly affect rural islanders who have never traveled west of Summerside, who have I might add, present company accepted. They have no concept of how far it is from Prince County Hospital to Skinner's Pond, Sea Cow Pond, De Blois, West Cape, Norway, and I could go on and on and on. And I think decisions are made in that regard. Just as an aside, a couple of years ago, my wife had a broken leg. We live in O'Leary. Our appointments with one of the bone surgeons in Summerside, Charlottetown, were consistently made around 8 o'clock, while people from Charlottetown were coming in at 11:30, 12, and so on. Just go back to the areas I mentioned. I doubt if you could get from any one of those communities to Prince County Hospital in less than an hour and a half if you followed the speed limit. I guess what I'm saying is we need more acute care beds in this area, but to get more acute care beds, I realize we need more surgeons, more doctors, not more surgeons, and doctors are a scarce commodity, and the bucks are scarce too. Mr. Minister, when your party came to power, and that applies to the other ministers as well, we were led to believe that we would have an open and a consultative government. We haven't seen open, and most of the consultations are after the fact. What we have seen in many cases is a government which hides itself behind an extra level of bureaucracy. And I think I better stop because my blood pressure is starting to go up, and Dr. Grimes would not appreciate that. Thank you.
Thank you, Bill. What other questions do folks have? If you'd like to come up to the mic.
I'm Carol Livingstone from West Point, and many of the things that I was going to say, Bill has already said, so thank you, Bill. I think that in many cases, we're feeling as though the powers that be look at us and sort of say, there, don't worry. We'll fix things for you, but we'll make the decisions because maybe you don't know enough to. And it feels like we're being patronized, and that doesn't feel very good. His point about where people live, I live in West Point. For me to get in to O'Leary is about 20 minutes. And from there to Tyne Valley, I checked with someone who works there. She lives just a few miles out the road, and it takes her 30 minutes or more. So I think, as Bill said, people probably making the decisions don't realize the distances and so on, and that there's probably farm machinery and there's school buses, and the ambulances are supposed to stay to the speed limit and so on. So it's very frustrating when you look in the newspaper or go to a meeting and you hear those things, because the people who live here know that those distances and so on are true. And I had jotted something down rather sarcastically saying, if the people in the Department of Health who deal with facts and figures don't know how long it takes to get from one place to another, how in the name of God can we trust them with our health care system? I've really enjoyed the things that I've learned this evening, and one of the questions, I spoke to a lady who from this area who was down in Charlottetown, and she met a former physician from this area, Dr. Pino, and he said, "What are you doing down here?" "Oh," she said, "I'm here to get a shot of cortisone in my shoulder." He said, "My God, woman, what are you doing down here? We were doing that years ago in O'Leary." But why do we have to go there for something as simple as a shot of cortisone in your shoulder? And that's supposing you can get in to see your doctor with the 6-week wait that Eva was mentioning. Like, you know, we get sick too, and it is so frustrating. And the things that you've outlined this evening are good, and they're interesting and so on, but we need something, and we need it now. I did notice, I had read the report about Saskatchewan, and they have collaborative care, and it sounds like it's working well. But they're also, from my understanding of what I read, they are keeping or even building new community care facilities because they realize that people can be treated closer to home with better results and less cost. So in many ways, it seems like we're taking a step in the wrong direction. And it's not only those of us who are from the rural areas that are going to suffer, because people in Summerside and Charlottetown, when all we country folk have to go there, they're going to have to wait. And that may not feel too good if they have to have the 8 o'clock appointments instead of the 11:30 ones, sort of thing. You know, there are a lot of questions, and I think we feel that we're being told what's going to happen instead of having a chance to participate, to have some input. And I think that's where the shoe pinches. I spoke to Robbie the other evening, and I had a lot of stuff in my mind, and I can't remember what his answer was. But I visited a cousin who's in the senior unit at the Margaret Stewart Ellis home. And going in to see him, I went by a number of those beds that are empty. And the rooms are there, and the beds are there, but the people aren't. What's happening? You know, it costs so much more to keep somebody in Charlottetown than it would in a rural area. What's the disconnect? You know, we want to know.
Well, thank you. I mean, obviously in the first slide that was presented, and I was supposed to mention, obviously last year we opened 8 of the 15 beds. And here tonight, on the first slide that Dr. Wedge showed, that the remaining 7 beds, the long-term care beds, will be opened up immediately. In respect to your questions regarding services, certainly I can appreciate your concerns. There is a high volume of, and as I indicated at the start of the presentation, as the Minister, I have to look at healthcare from tip to tip. There's also, and we can't lose sight of this, there's all kinds of islanders, whether they live in Croppo or Summerside or Tignish, that are getting services either at the Prince County Hospital or the Queen Elizabeth Hospital. I believe it's about 1,100 islanders a day from tip to tip are coming in to get a range of services that aren't provided in other areas of the province. No different than approximately 25,000 islanders left the province last year to get a service in some facility or some healthcare hospital, whether it be the Victoria General or the IWK or in St. John or in Toronto, that service that is not provided here in the province of Prince Edward Island. As I indicated, our out-of-province budget is our second largest hospital, but it's out of province. So that does require, depending on the type of need, whether it's cardiac care, neurosurgery, or some type of service that's not provided here in the province. So islanders do leave the province for a level of care. Islanders do come in native communities to get a range of services. And the focus on the direction forward is making sure that we utilize all our buildings and all our facilities to their full capacity and their full potential. And as I indicated, we have approximately 80 beds across the province that are acute care beds that are being used by ALC patients or alternate levels of care. So we want to use our facilities, and as I received a phone call this morning from a very upset individual who is very well known in the community of Charlottetown, very upset because a close family member was transported last night from the QEH because, and they were transferred to Surrey. And I said, that is the direction, and if we can drive in, they can drive out type thing. So that's a clear message last night. I brought in a repatriation policy, and what the policy was before Christmas, and I've told all the MLAs that sit around the caucus table, do not call me when a family member or an individual or a community member, particularly in the Charlottetown area or the Summerside area, gets displaced to a community facility because we have an empty bed, because we have to free up a bed for a more sick islander at the PCH or the QEH. So that is a clear message, and I receive at least 2 to 3 of those calls a week from people that live in Charlottetown saying, you know, we can't send our mom or our aunt or our cousin to Montague or Surrey or Western. And I said, oh, yes, you can, because that's where they have to go, because we have people, we have frail elderly seniors sitting on stretchers for 6, 8, 10, 12 days waiting to get into acute care beds. And I know that the evidence shows after 6 hours, after 8 hours, the health outcome of an individual sitting on a stretcher deteriorates rapidly. So that is my focus, that is my priority, and we have to use all our facilities and all our beds to our full potential and capacity to address the issues that we're facing here in the province.
That was an interesting answer, but it didn't answer the question that I asked. The question that I asked you would have helped to satisfy the answer you gave me. You said there's people crowded in the beds down there, and I said there's empty beds up here waiting for people. We need to get that transfer going. But why are we waiting for it? They've been sitting there. You know, they opened up some, and they're beautiful in their new rooms, and we're glad that we have them. But with the people sitting down there taking up space in the more expensive acute care hospital, Why aren't they put up here? What, what's the delay, I guess is what I'm saying. The beds are there.
I think the minister did answer, but I'll try and clarify it. So last year, the beds were built in the O'Leary area, the 15-bed extension that occurred to the Margaret Stewart Ellis. We received funding at Health PEI to operate 8 of those beds last year. The budget just came down, I'm not sure exactly when, 1st of April, whatever, and there's an additional funding now being made available by government to operate the other 7 beds. So those empty beds that you're seeing were not funded prior to this budget. They're now funded, and we're staffing for that, and we'll be filling those beds.
Relatively soon, or?
Well, essentially what needed is we need to get the LPNs. There's LPNs, there's some nutrition staff, some cleaning staff that have to be added to the system. So we have to hire some of those. Some of them are casual. They'll go fairly quickly. But we have to make sure that we have staffing 24 hours a day to make sure those patients are looked after. So the next month, somewhere pretty close. Won't be
Okay,
long.
thank you. That's the answer I was looking for.
Yeah.
Hi, good evening. I'm Thelma Phillips from Foxley River, which is in O'Leary, Inverness. I'm also a member of the Stewart Memorial Hospital Auxiliary, a proud third-generation member of that organization. Back in February, I remember reading an article, I think it was in the Journal, of a speech you gave, Dr. Wedge, maybe to the Rotary in Summerside, talking about the design, I don't know the lingo, but the design life of Prince County Hospital, and that it was, I think it was a 15-year span, with the loss of acute care beds from Stewart Memorial and from O'Leary. I assume we will be going to Prince County for our acute care services. What will that mean after that 15-year time span? How will Prince County Hospital change? Are there changes to services that we should know about or that will impact us in West Prince?
I think essentially what we were looking at in that, as part of that presentation to the Rotary Club, was around when the Prince County Hospital planning was occurring in the late 90s, early 2000s. There was a 15-year demographic projection as to the age of patients, the number of patients that were projected to be in the usual catchment area of the Prince County Hospital, and they projected that out for 15 or 20 years. So those projections are starting to get old. The Prince County Hospital started to be built around 2001, opened in 2004. So that's what we were talking about. So essentially what, as part of the presentation that was there, was around, it is now time to look at Prince County Hospital and see if the mix is correct. So for example, we now know that the population is aging faster in the East Prince area than projected. And Prince County Hospital is what we consider the referral hospital for all of Prince County, and then part of the rest of Prince Edward Island also receives services at Prince County Hospital. So what happens is, I think there are 40 acute care medical beds. I'm just looking at Arlene here. 40 acute care medical beds that were designed, whether we need 42 or 44, whether we need a couple of fewer surgery beds, a couple of fewer pediatric beds. So those are all the mix that has to be looked at. The same number of beds is projected, but if you go into Prince County Hospital now, you'll see medical patients that are on surgery, you'll see medical patients on pediatrics. So we need to kind of redo our mix so that medical patients are on medical floors, pediatric patients are on pediatric floors, and surgery patients on surgery floors, that kind of thing. So that's what we're looking at. Yep.
I will say that, and
What?
I will say that...
Too small? What's too small? No, there are people in the beds, but you're right. No, the people are medical patients that need to be admitted to the hospital. If the bed is empty in pediatrics, then we have to put adult medical people on the pediatric floor, and that's not appropriate to have adult medical patients with little kids. It's not conducive to anybody's treatment. Right? So what you're saying is we should build on to the Prince County Hospital? Okay.
all that extra money.
I'm not saying it's too small. I'm saying we have the right number of beds that need a different mix.
Is that planning ongoing? Is that readjustment ongoing? Or will there be a period where you say, okay, here's what the new plan is for Prince County Hospital?
in hospital systems, they need to do this planning every several years, whether it's every 10 years or so, to make sure that they're meeting the needs of the community at the time. Yeah. So it hasn't been done for quite a while. It has not been done for 35 years at the Queen Elizabeth Hospital, and it's being done there too.
I appreciate your answer. Thank you very much.
Okay.
Just to comment, one of the things that when the Prince County Hospital opened, the new facility, I believe it was in 2005, 2004, there was the hospital was built with 50 less beds than the former facility that operated prior to its opening. But certainly, just a couple of comments I want to make in respect to bed usage and so on. One of the issues, which is part of the big picture challenge for the province and provinces throughout the country. The federal government, and certainly I don't spend a whole lot of time pointing fingers and blaming, because it's been clearly presented to us that the federal government now is engaged in a transfer of payments to provinces as far as healthcare transfers. When publicly funded Medicare was introduced in the late 50s in this country, it was built on 50-cent dollars. And through federal governments, both colors that have come and gone, that has dwindled down to approximately 18 cents on every dollar spent here in the province of Prince Edward Island. So right now, we would spend $570 million. So we are supported by the federal government in that agreement that was built for publicly funded Medicare with 18 cents in every dollar. So that obviously has evolved, and I'm not pointing fingers to any government, but the clear message from the government of the day is that healthcare is a provincial jurisdiction. Here's your transfer, 18 cents in every dollar. You do with it what you have to do with it. So provinces, not only here in the province, have to be very innovative, and we have to use our assets, and we have to work extremely hard to make sure that we get the best service we can with the budget envelopes that we have. And whether it's an out-of-province service or whether it's a service that is required for somebody in the area, in Summerside or Charlottetown, or it's a service here in the community, we have to use the resources we have to their full capacity and full potential. So we also, when we came in 2007, there was a moratorium on long-term care beds. So at that point in time, there was a complete freeze on any new long-term care beds. So we lifted that moratorium, and we rolled out a long-range plan to add long-term care beds in the province. And right now, I think we're up to about 160 to 170 beds that are distributed throughout the province of Prince Edward Island. But of course, we're in a different time than we were 10 years ago. We're 10 years older. When publicly funded Medicare was introduced, the average age of a male in this country was 27 years of age. Today, the average age is certainly a lot older. So it's a different time, different pressures. Medicine has evolved, different technologies. Physicians work differently than they did 25 years ago, 30 years ago. So lots of pressures and challenges facing our system as we continue to try to evolve. And I'm not pointing fingers and blaming. We had to make decisions on emergency rooms. Former administrations had to make decisions on emergency rooms. The system is evolved. I remember when the ground ambulance fleet, and I say this publicly, we've got a highly skilled, trained, world-class fleet of ground ambulances and professionals that work in them. And that was a very controversial decision at the time by the government, but it was a very, very strategic investment for the future of healthcare delivery here in the province. So I just wanted to add that. Thank you.
Thanks, Doug. My question, actually, I'm Paula Bigger. I'm the MLA for Tyne Valley Linkletter, and for the last month since we started this announcement and process, I've had a lot of discussions with different constituents in regard to the realignment of our beds at Sturt Memorial Hospital. One of the real concerns for people around long-term care beds is if they reach their end of life and they can't, the perception is they're going to be shipped out as soon as they start to die because we don't have a palliative care bed. So that's a real scary concern for those people in our community. So maybe you can clarify that if indeed you are in a long-term care bed and you are at that stage where you're end of life, all of a sudden, are you going to be shipped up to O'Leary to finish dying, to put it very crudely?
That's a real concern. And the other question is for Marnie about recruitment for our weekend clinics in Tyne Valley.
I'll start with the palliative care question. Palliative care is something that we expect that should occur in the long-term care bed. There shouldn't be anybody leaving their home and that has 24-hour nursing and then being transferred to a palliative care bed. So we have a couple of programs that are out there. The palliative care home, the drug program that adds extra palliative care drugs to long-term care homes in order to make sure that the right drugs are there for the patients. So that's what should happen. I will speak to the palliative care program physicians and ask them to go up and review with the 2 physicians in the Tyne Valley area to make sure that they're aware of that. There will be a number of policy changes that will have to occur. But no, they should stay in their home to receive palliative care.
I think I better clarify that, Richard. You're referring to the home as the hospital. I just want to, because that messaging is not clear.
Yeah. So when
you say home,
when they go to long-term care, that is their home. Okay. That is their home.
Thank you. I just wanted to make sure everybody was clear on what you were saying here.
Yeah. So it's just like if they're in a hospital awaiting long-term care, it's not appropriate for them. They need to be in what's their new home. Yeah.
Just on your question on alternate weekend coverage, we did send notices out across the province to all family physicians looking for support, and Dr. Mohammed has agreed from Summerside Family Physician. He's going to be providing coverage, I believe it's once, I didn't bring all of my details with me, but I think it's once a month from now until, on Saturdays, on the Saturday clinic, and now until December, he's provided some commitments. Okay?
My concerns is about the ambulance. I had called an ambulance for my husband a while back, and when we left our house, the ambulance went down. I'm not sure if you're familiar with this area of the road system, but when we left the house, I followed the ambulance down to the hospital in Summerside. And when I turned off on the Elland, they took the back road down, and I turned off on the Elland Road to get out onto the highway. The ambulance took Lot 16 route out around the back of Muscush and all the way around through Muscush and down into Summerside. I'm wondering how do they get the routes in which they should travel for? Is it done based on a GPS system? Is it done based on time-wise? How is that done? I got to the hospital about 10 minutes before my husband.
Sure. Thank you.
And he's in an ambulance.
Thanks for your question. Great question. Our ambulances are equipped with GPS mapping, so every unit is equipped with GPS mapping. Our paramedics, in a lot of the cases, know the area. So there's a couple of different things that determine which way the paramedics travel. So if they're traveling lights and sirens, obviously it's an emergency and we try and take the quickest route possible to the facility. If they're traveling non-lights and sirens, there's a couple of things that may play into factor. If the individual's in pain and one route is more bumpier than the other, they may take we give it to their discretion where the patient's not an immediate life to either or risk to their life or limb. We give it to their discretion that they can take a little bit of a slower route if it's more comfortable for the patient. Sometimes it just may be a couple of different factors such as road construction, whether the road is susceptible to conditions. If it's like a dirt road and the weather's a little bit inclement, we may not want them to go down that. One of the things that we're looking at in the coming months and have planned is each of our ambulances are going to be equipped with tablets. Our paramedics are going to have a computer-based system inside the ambulance, and they are going to be equipped with mapping. What we're looking for right now is an interface to the Department of Transportation mapping. One of the risks, we have GPS, and the only reason that our ambulances don't have visual mapping right now is there is a risk with every everyday mapping. There are certain roads, especially in Prince Edward Island, that are impassable in the wintertime because of weather, farm roads, things like that. One of our big fears is that we introduce this mapping without the Department of Transportation overlay mapping of road closures. We need to make sure that the paramedics have up-to-date road closures and that that information is accessible. So our fear is not necessarily once they have the patient and are going back, but if they're responding, let's say, to your residence, and the shortest route is depicted to travel down a road that's impassable, it may end up in a full delay for those paramedics. So I guess the long answer of all of that is, in some cases it's their discretion, but we're looking to do a more formal process where we'll have actually plotted mapping, and it would be sent to the paramedic crews which way to respond back.
Thank you.
Thank you.
My name is Joyce Madigani. I'm from Tyne Valley. Dr. Wedge, I would like to thank you for being here. We missed you at our Tyne Valley meeting. So, my question is, we had a consultative committee that was formed at the direction of Health PEI. We spent months deciding what was to go to Tyne Valley and what was to go to the what was to remain at Stewart Memorial Hospital. We had a meeting on the 21st of February in the dark that was cancelled. And after that meeting, you were gracious enough to come to our hospital on the 28th of February and do rounds with me. And you looked at the place and you were shocked and told me that this place wasn't fit for long-term care. The stairs were rickety, the people were disabled, they couldn't be taken out of the building in a fire. And you also told me that there would be a study to see how we could improve the place. I have two questions. What happened between the 21st of February, when we were having a meeting to tell the people about the two parallel things that were going to be in Tyne Valley, and the 13th of March, when the government suddenly came out with something totally different from what we had been discussing for a whole year? I don't want you to be briefed by the minister. I need an answer from you. And the second question before I finish, or a comment, that lady you talked about who was in the ambulance 4 times at $150, she ended up in Tyne Valley Hospital acute care. That's where she was eventually treated. We are now not going to have acute care. In fact, we don't know what we will have. We have requested that we have a proper consultation with our resolution, and we hope that there will be a positive response and a consultation. And I am inviting you again and inviting the minister to please come time to Tyne Valley and have a look at us again. Thank you, sir.
Thank you, Joyce. You're exactly correct. The direction as of last summer was that the outpatient department was going to close in Stewart Memorial. The what? So last fall, it was announced the outpatient department was going to close at Stewart Memorial. Staff from Health PEI was working with the community around what services are going to be available, just like you're saying. There was a plan for a consultation that, unfortunately, the power was out, as people know. We didn't know that, of course, on our way up to Ellerslie that night. What we knew was that the power was out, but we didn't know it was going to be out for 4 hours. There were a group of people that were in that room who said they wanted to sort of wait till 7 o'clock to see what's going to happen. At 7 o'clock, they took a vote and said they wanted to have it on another day, and that's what happened. So the plan was the outpatient department services were closing. We were looking at transferring those services there. The problem, as you quite rightly point out, is that a government decision was made in the interim, and there's a new direction. So we're now going down the road of a new direction. So that's where it is. So we did go around and have a look in some of those rooms in Stewart Memorial. Some of those rooms are not what I would call appropriate for people in long-term care, and that's why we do have a facility review underway, and the engineers are having a look at that facility. The facility belongs to the Department of Infrastructure Renewal, and they will give a report of what's going on and what's needed to be done to bring that up to a long-term care facility. And then, for example, the lady that we'd seen in one of the rooms that needs to have a better room for long-term care because it's not appropriate, the room that she was in that we were talking about. I do agree with you. So we need to fix it.
When that place was, just to let everybody know in this room what happened. In 1984, former Premier Jim Lee built the back room of Stewart Memorial Hospital as an extended care facility. It was never built as a long-term care facility. Now, Tyne Valley does not qualify for extended care facility in the new plan. Although we had a place built for long-term care facility. We were a little bit advanced at that time, 1984, okay? However, my concern now and my request is that Tyne Valley should have the same standard of rooms as we have in other facilities. One room, one person, one toilet.
I don't think anybody's going to disagree with you.
Okay, and therefore I request that the minister please have more consultation with the community so we can reach something decent and agreeable.
Sure. Thank you, Dr. Medellin. Just in respect, and I shared at the Tyne Valley meeting because some of these questions are focused around the services in Tyne Valley. Certainly, and I see Rod at the back coming to the mic, and certainly we've had some informal conversations regarding the facility. Certainly, I don't have any formal engineering structural review. I've been in the facility a number of times. The facility has served the community very well, but certainly it's been brought to my attention via staff at the Stewart Memorial Hospital on concerns in respect to issues. So the responsibility to assess the building, to see if it's meeting standards on fire code and etc. is their responsibility. And certainly once I see that information, certainly as I've mentioned to the MLA from the area, Paula, that we will be in discussion. And I think we're fortunate. The facility's there, but there's also a facility across the street, obviously, that you're well aware of, the new facility. And I think in respect to Tyne Valley, we have to be thinking about the future of services in the area. We know that infrastructure and we know healthcare providers don't last forever, and certainly as the minister I recognize that. So we need to continue to look at the future of services. And once that information comes forward, at this point in time, I don't have that information. So thank you.
I'm just looking. I see Helen there, and
we have tons and tons of questions. We request more time. You gave it in Surrey and Tyne Valley. We want it here. We want another hour. And my first question. Why is the heart monitor at Community Hospital locked in the closet? Oh. And, well, Tyne Valley had them in the basement, the beds, so I guess the heart monitor doesn't mean too much. But you mentioned there the heart monitor was going to be available. It's locked in the closet. Okay? My next thing. It costs $949 a day. That was last year. I don't know what it is this year because I realized that the first of the month the prices would have went up for the beds at Prince County Hospital. You have this new facility, you say this 10-bed? 10 Andrews Lodge coming up. Can you put some of those in there? Let's look after Prince County before we look after the rest. Prince County is our main hospital up here. We want it cleared because we're losing our acute care beds all over the place. We need them. We want to look after Prince County Hospital. And by putting them in there, you're going to save a lot of money by putting them in Andrews Lodge, unless, well, I can't figure out this that's $50,000 a bed, but anyway. My next question is, how are you saving money shipping people up and down the road? The only one that's benefiting for it, I'm not finished yet, the only thing that's benefiting is the ambulance service. Is it fair to us old seniors, as you call us? There's a lot of us out here. We voted for you, some of us. Some of us may not be doing it again. But is it fair to them? Who's going to pay for this? Are we paying for it if we have to be shipped from an acute care down there to be convalescent somewhere else? Who's paying? Are we considered urgent or emergency or non-emergent? Because I understand that for seniors, emergencies are free, but $150 if it's non-emergent, and that came from the business office I called the other day. So who's going to be paying this? Us guys that have to be shipped from one end of the island to the other? Or you guys? Who's paying?
Thank you very much. I think I can, in respect to the long-term care beds, obviously there was an RFP that was put out publicly for 55 new additional long-term care beds. That RFP was announced. Obviously, I was at the Mount in Charlottetown, where the Sisters of St. Martha's, where the announcement was held. Those 10 long-term care beds will be going to Andrews, just in Summerside. In respect to the beds, I think the cost of an acute care bed in the system today is in around $1,100 today. In respect to bed usage, this is the whole direction and mandate that we're moving in is trying to make sure that we protect particularly our acute care beds at the PCH and the QEH for our most sick islanders. And there's people from all across the province that are getting healthcare services in Summerside and Charlottetown at the two larger facilities. I recognize that. But we also recognize that there's huge bed blockage issues in respect to the number of people that are tying up beds all across the province, particularly even in Charlottetown and in Summerside, that can be transferred out so we can open up those beds for islanders who are sitting on stretchers in those larger facilities. So I think that answers a few of your questions, but keep going and I'll stay at the mic here.
Andrews Lodge. Are they building a piece onto Andrews Lodge?
I'm not aware of what
I can answer that question
okay, sure.
if you'd like. Andrews Lodge, they were told in the fall to sort of downsize those beds, so they're down to 10 beds. Now the province is paying $50,000 a bed. For 10 beds, that's $500,000. Did that not cause like your bottleneck, whatever you're saying, in the system? Those were available all the way through. Some of us guys up here could have had surgery in Summerside Hospital, or Charlottetown.
Yeah.
Like here's one that's waiting for a knee. I could have been there.
Yeah,
it's really upsetting.
Andrews and Summerside, a number of years back, it is a community care facility which addresses the needs of individuals that are identified as level 1s, 2s, and 3s. Long-term care are identified at levels 4s and 5. Andrews and Summerside supported and took on 10 beds a number of years back, and through this RFP process applied and were given 10 additional beds. I haven't been in conversation with Andrews and Summerside about whether they're adding infrastructure, but they do now have a total of 20 long-term care beds. So that's as much as I know, but we certainly will follow up on that.
They had been putting people out of, like not out of the beds once they die, or they went to another level of care, or they moved to another province. Those beds were vacant, and they weren't filling them till now.
I'm not
So that
clear
caused a
on
bottleneck.
the Andrews is a privately owned facility. They have had 10 temporary beds, which we identified as permanent, and we just awarded through the RFP process 10 additional. So as of today, they have 20 long-term care beds. Certainly how they're running their facility, I can't speak to because I haven't had those conversations with the owners and operators of Andrews in.
What about the Atlantic Baptist? Is this the same situation?
Atlantic Baptist.
Is that a new part on or what?
The Atlantic Baptist in Charlottetown was awarded 15 beds in the RFP process. They will be investing in new infrastructure because they are at full capacity. The reason why we RFP'd the additional long-term care beds, because all the beds, there was no additional space in all the private sector. So the RFP allowed Atlantic Baptist, for example, to present their business model, to identify what number of beds they would need. In discussions with them, they needed approximately 15 beds, and we're prepared to invest in the infrastructure and the capital dollars. But before they do that, they need to know that those beds are going to be there for them.
This $50,000 a bed, is that going to be yearly or annually, I should say?
Basically,
or is that a one-time deal?
Approximately, government made a decision when we announced that we were replacing the 5 public manors. At that time, we said no additional beds would be added in the public sector. The buildings would be replaced. All new beds were going to be added to the private sector. And the private sector is lined up. There's facilities all across the province that are into the long-term care business, whether it be Andrews and Summerside, whether it be the Atlantic Baptist, whether it be the Garden Home. So the private sector has been a great partner in respect to the long-term care business for the province of Prince Rhode Island.
I understand that at the manor, like my mom is at the manor here in Alberton, and she's private pay, so I don't know what the pay is, but I understood from the scale that came out not too long ago, it's $77.60 per day for a patient in there. And anyone that has an income less than $30,000, they would be subsidized by you people. So when you figure that out, it costs about twice as much to put a patient, not quite twice as much, almost, twice as much to put a patient at Andrews Lodge as it is to put one at Maplewood Manor or the manor over here. Why not take that money and put an extension on some of our facilities up here? I mean, when it's twice as much, why? If you're going to pay that subsidy every year, $50,000 per bed, I mean, it's...
You know, as I indicated, long-term care patients are level 4s and 5, and they need a certain standard and level of care. You understand that?
I understand the levels very well.
Okay. So obviously, we need 24/7 nursing coverage. There needs to be, they're long-term care patients, and they're identified as level 4s, level 5s. So the standard model of health care that's provided to them is a different level that's needed of individuals that are in community care facilities.
Okay. So now, when I added up the figures for all the facilities on PEI that need long-term care, the figure added up to 77.3. I think that person must be armless and legless, that 0.3. But Margaret Stewart Ellis is getting 7 more beds. There's 24 beds, I think approximately, at Unit 6. Now, you mentioned the other night, Dr. Henderson mentioned that there was no call bell system there. Did they rip it out of the wall and tear the plaster? I can't imagine government going to that expense for repairs. The oxygen system has a valve. It would have been shut off. Back when SARS was going to be the thing, we were going to open it. I was on that committee. And we were going to open that to use for SARS patients. So what is wrong with it now?
I can't speak specifically about the question, but certainly from an operational level, I can get Dr. Wedge if he has capacity to understand that question, because I certainly have no understanding of...
Well, that's all right. I just wanted you to know that, that we know that. Now, that makes 84 or 85 beds with the new 55. So that gives you 5 or 6 left over. So you're going to be in pretty good shape in the next little bit. And by the way, I want to go to the Mount because it's beautiful. So why not start getting towards building something else now while you'll be ahead of the game when you get to this? Don't wait till we're in a mess like this.
I certainly appreciate your questions. I don't necessarily agree with your numbers and your data. Obviously,
you put them up there.
The private sector obviously is very engaged in long-term care. They've been involved in long-term care for decades here in the province of Prince Rhode Island, and they do a fantastic job. The private sector is willing to put up capital. The private sector is more efficient so we as government are looking at efficient ways to provide long-term care. We're investing in the beds, and the private sector is building the infrastructure and providing the care all across privately owned facilities across the province of Prince Rhode Island. And they do a wonderful job.
Oh, yeah. Anyway, another question. I wonder who's doing the doctors? Ms. McCrae, Dr. Montgomery is 80% up here. Dr. Burley works half-time in Tyne Valley. She's only half-time up here. No, she doesn't. That is what comes from the medical people. So we're short of one, even 1.2, say then, if you're going to count that she's up here. I know we're all one region when it comes to money. We're the 12, the West Prince area is Tyne Valley and O'Leary and Alberton. But then in the paper, or the end of one of your slides, for one of the things that came through, you mentioned that when the CEC model comes through, there's going to be 7,500 more appointments, and that it would be equivalent of one more doctor. Does that mean we are not getting the doctor that we want?
Thank you very, very much, and another good question. Obviously, which was presented tonight. Obviously, recruitment. We've laid it out we're very aggressive. We're spending huge dollars. We're actually trying to entice new family medicine physicians to come back to rural Prince Island with not only a $110,000 check, but an additional $50,000 as well. We've got in the western region, we've got one vacancy with a complement of 12 physicians. So if you look at the population base, that figures in around 1,200 patients per physician. There's one vacancy, so those numbers certainly aren't at that. But if you look at the investments, the residency program has proved to be a huge success. We basically recognize that the investment that we're making at the medical school in Memorial, which is buying seats for island kids to go to med school, that program was brought in 2000. As the minister, I'm not real happy with the return on investment to date, but we're working with Memorial to look at ways that we can continue to attract physicians to the area.
That's not answering my question.
Okay.
I asked you if that statement meant we're not getting a doctor up here.
The commitment is to fill the 12 physicians here in the West. The commitment is to fill the nurse practitioner vacancies, and we're fortunate. The first class of graduating nurse practitioners will be completing their program this spring, and I had the opportunity to attend a graduation with 12 critical care trained nurses, and 8, I believe, are from the Western region. So it would be ideally, if there's nurses in the area that want to participate and become nurse practitioners that want to return to the communities, that would be the best case scenario moving forward. So we are moving the agenda, and unfortunately, we are not in the position where we can force physicians to work in communities. They make those decisions. We have control over the type of climates and the primary healthcare networks and the collaborative models they work in. That's how we're going to attract physicians and retain them and keep them in our communities in Prince Edward Island.
Thank you.
Yeah.
Thanks, Helen.
Next question. I'm asking questions for other people that want things asked, and just in case you're wondering. You mentioned the other day that there's 66,000 surveys went out. I want to know in this room how many received a survey in the mail. Anybody? Hands up, please. 3 or 4. Well, that's the first time, because I've asked everybody I can find and nobody answered that they had one. I did it online. There's a few of us that, check your websites and keep track of all this stuff, and we did it online. But there's not too many people got it. How about letting us do another survey? Let some of us volunteer to do a survey on what we think of the health system up here. I've been on that committee that you had in O'Leary that day, the focus group, I think you called it. It didn't focus on things we wanted. It focused on what you wanted yourself.
The survey was sent out to all households on Prince Edward Island. There were 62,000 households that were there, delivered by Canada Post to every post office box. Well, there were around 12,000 people returned them. So obviously they were going out. They were paid to go out to every household, and that's what we did. Yeah.
I can check the post office if you want.
Yeah, the online survey was part of the strategic plan survey. It wasn't for the primary health care survey. The primary health care survey was about a year and a half ago. Yeah. Okay.
Hi, my name is Michelle Arsenault. I'm from Devar, so I am in Robbie's district. We've had some great chats. I did speak at the Alberton meeting, and I do have a little badge that says Alberton because I consider Western Hospital to be my primary hospital for this area. It used to be O'Leary Community Hospital, and it was a couple of years ago, actually 2 years ago, that my son was sent from the clinic here in O'Leary by ambulance to Summerside. And the ambulance driver at the time had told me that O'Leary wasn't considered a hospital by them anymore. So I'm here advocating for Western Hospital Emergency Service. I'm also here, I'm glad to see, Marnie, that you're here speaking about recruitment. I recently got a family doctor after not having one for 2 years. I have 3 children, myself and my husband. This is our 6th family doctor in 12 years. So, my question is, you spoke a lot about recruitment, and recruitment seems to be ongoing from what I've seen. I'm wondering, what steps have you made for retention? Have you done pre-interviews and post-interviews with the doctors who've chosen to leave? I wonder if you can speak a little bit about what you're doing, not just for recruitment, because they do come here, but they don't stay.
Okay. I mentioned a little bit earlier about the RICH committee that's involved with the Newcomers Association. This is a new committee that started up in the last 2 years, and staff from my area, our physician recruiter and our health recruiter, have been very active on those committees. From a retention perspective, one of the things we saw with the international physicians as well was that they needed additional supports when it came to orientation and integration. And so orientation programs have been created and developed and are being given to those new physicians, especially the international folks who help integrate them better into the health system here in PEI and in Canada. From a retention perspective, there are challenges. So when we say we started this new program and we look to the community for support, folks that have left, we do survey them, those that will sit down with us and talk to us about why they've made the decision to leave. Some choose to leave and not share a whole lot with us, but we do sit down with them, and if they're available and will agree to, and ask for information from them. Why are they deciding to leave PEI? And some of what we're hearing, when I mentioned earlier the workload, that's one of the things that we've heard from folks who've decided to leave. And the other area, sometimes they find it hard to integrate into the communities. And so new to a community, that's why this new program is up in place. In one of the national committees I'm involved with, they're looking to this piece of work that's being done here and saying PEI is ahead of the game. We have communities like this when it comes to integration and retention, and if we can start to put these kind of communities, have the communities involved with the retention piece and integration, that it would be a huge benefit. So we're hoping that people will help us with that piece of work for sure.
So how long has it So this is a new program that
Yeah.
you've brought in. How
It's-
long has it been in place?
It started in Summerside as a pilot, and the PEI Newcomers Association are the ones who received the funding, and we've been involved with the committee. And Summerside has helped to integrate a significant number of health professionals, not just physicians. We're looking at all health professionals, especially the international folks, and it's sat down with them and worked with them and their families. It's helped them to integrate into the schools. It's worked with the kids in the communities and helped them to find sports, connect them with all kinds of different activities. So Summerside started. It was a pilot in that community, and then it moved down to the eastern end of the island a year ago, and it's just getting started up here.
So it hasn't really gotten underway up here yet?
It's just getting started.
So what kind of results have you seen since it came in place in Summerside?
Well, we've had some really good comments and feedback back from the physicians who have had the support, especially in the Summerside area, because it's kind of been underway for a while now. They have a navigator in place, and the navigator works under the Newcomers Association, and that's their role, is to help them find all the things that they can about the community, and they've been very instrumental in supporting them, and the feedback we're getting from those physicians that they've worked with has been really positive.
Okay, thank you. I have a few other questions, if I could just ask them all at once. I do have a couple questions for Matt regarding the new scenario that we're looking at possibly for Western Hospital.
Yep.
I know that we're looking at after 8 p.m. that it will probably be staffed by a nurse and a paramedic. If a patient, and maybe this might be not just for you, it might also be for Dr. Wedge, if someone comes in after 8 p.m. and they are, the staff on site are not able to care for that person, we were told that they would be transferred by ambulance to Prince County Hospital. Will there be a fee for that service?
I'll start the question. There hasn't been, to my knowledge yet, there's been two scenarios thrown around for the collaborative emergency care centers. There's been a nurse-nurse model, and then there's been a nurse-paramedic model. So those discussions have just been very preliminary on our part. We are able to facilitate paramedics within the facilities. Our sister company in Nova Scotia has done it and done a great job over the last couple of years. So I'll maybe turn it over to Dr. Wedge to answer, as it's really a health PEI decision at this point. So we're just willing to support. Did you have another question?
I did have another question since you're at the mic.
Yep.
You did say that Island EMS is a provincial company, but I think you meant that it's island-wide. Is that
Yep.
correct?
Absolutely.
So you're a privately owned company.
We are, yep.
Can you tell me roughly what was the profit margin for Island EMS last year?
So, without speaking, we have a contract with the province of Prince Edward Island. If you were requesting financial numbers, you would have to go through Health PEI for that.
Mm-hmm.
We are a private company, and we hold a contract with Health PEI, so those numbers would go through Health PEI.
Yeah, I'm just wondering, so you did make a profit last year, you didn't go in the hole.
Right. It's always, as a company, I can tell you, and I'll talk just a little bit from from Island EMS. As a company, we have to be sustainable, so we do make some margin of profit. But really, if you look in the last couple of years, hopefully you've seen the investment which we've made back into the communities. I've been general manager of Island EMS for over 2 years now, and the 2 years that I've been here, we've really moved leaps and bounds and reinvested back into the communities. We've purchased 8 new ambulances with power hydraulic ambulances. We're looking at tablets. We've added an additional unit ourselves as Island EMS without any government funding. We looked at our on-call unit. We added a 12-hour, 7-day or 5-day-a-week unit to the Charlottetown area because we found that the demand was high within the province, and we wanted to help alleviate that. Health PEI has been excellent in the Department of Health with working with us collaboratively, but we do as a company really try and invest back into the communities we serve. Our our corporate company, Medivie EMS, also has a foundation, the Health Foundation, and it does put a lot of the profits made from all of our companies back into the communities we serve, and it's actually on the Medivie EMS site. So they do funding of projects such as diabetes in juveniles, mental illness, things like that, where they fund activities, put the money that we make as a company back in to support the communities for the residents who do pay their fees.
Thanks for your answer, Matt. And I want to say that you seemed really well organized and you seem to know your facts and figures pretty well, and you seem to do a pretty good job of running Island EMS. I wonder if maybe we might be able to get you to run Health PEI, and we might be able to stop having such problems with deficits.
Thanks for your comment.
I just have one more set of questions for Dr. Wedge.
CEO position was advertised. Just
That's great. I was going to ask you, Dr. Wedge, so you were a medical doctor before you went to work for Health PEI, or you still are a medical doctor? I'm assuming it's not an academic doctorate that you have?
That's right. Yeah.
What was your practice in?
Practice in family medicine in Summerside and emergency medicine in Prince County Hospital.
And did you find that to be, was that something that you wanted to do from when you were a young person going to university?
Yep.
Okay, so when you were going to university, did you take a lot of courses in statistics?
We did, yeah.
And so you've presented a lot of statistics here tonight. You've presented a lot more in Alberton the other week. Did you do all the statistical analysis on those graphs that you presented yourself?
Nope.
Who did?
There's a number of staff in the health information unit to do that. Yeah.
And did you make the graphs yourself?
Nope.
And so the staff did that for you as well?
They did, yeah.
And are the statistics that they used available that other people can have a look at these statistics?
Sure.
Because we've had some people ask for access to these statistics and we so far haven't received any answer. Mm-hmm. Do you know what the term cherry-picking statistics is?
Sounds good. Where are you going with this?
I'm just asking if you know what the term means.
We try and ask statistics. We try and present statistics that are of value to the meetings that we're here. But if you think that we should present something, we're happy to present something.
It just seems that when you cherry pick statistics, it means that you pick a specific set of statistics out of a data set. I've studied a lot of statistics, and you pick out a certain data set that supports your position and use that when you're making your graphs. I don't know if you noticed at the Alberton meeting, but I had about 3 rows of people sitting behind me who were staff at Western Hospital. And whenever you had some graphs up about the wait times at the ER and the number of visits, what time of day, every single one of those people were shaking their heads and saying, no, that data is, those graphs are not correct. So I'm just wondering what you have to say to that. Are those statistics out there that we could analyze a little bit more? Why is it that the staff from the hospital think that those statistics are incorrect?
Those stats are sent to Dr. Montgomery every second week. They're based on the time of arrival in the outpatient department, the triage level that's put in there, and those stats are available to him every second week, and if he wants to share them, he's welcome to.
There was one statistic that said that the average wait time at the ER was 1 hour and 40 minutes. There's a lot of people here, and I'm just wondering if I can get a show of hands from people who have actually been to the ER at either Western or Prince County Hospital in the last year or two. How many of you, keep your hands up, how many of you waited less than 1.4 hours? Less than 1.4 hours. And how many of you waited less than 3 hours? How many of you waited less than 5 hours? So, and some of you waited more than 5 hours.
And
So there's a little data set right there.
Yeah, so for example, at Western Hospital, it varies on the day depending on which doctor is working. Some of the days are much busier than other days. People will go by and they'll find out who's working. If it's their family doctor, you'll find that out. So if you look at the total numbers of days at Western Hospital, you'll see some days that have 30, some days that have 50. So on the days that are busier, they're going to be longer than the days that are not busy. So when you average those stats out, you'll get something. It doesn't say the longest wait, the shortest wait, it's the average.
Well, I just asked you the question earlier what your practice was, and my suggestion, Dr. Wedge, is Marnie is here and we have an opening for a family physician in West Prince. So maybe if you really want to get to know what the needs are in our community, you could come up and spend some time working here, because statistics doesn't seem to be your strong point.
Thank you.
Thanks.
Thank you.
So just to let you know, I have worked at Western Hospital for a number of years and very much enjoyed it.
I see Rod and I see this gentleman, this tall gentleman at the back, and I'm going to suggest that we wrap up the questions.
And you really don't have to hear from me either. I mean, it's up to the chair. I know, people, you guys have, it's been an exhausting 2 weeks. Oh, I know. And believe me, the word Tyne Valley is not going to be used again. What I want to speak about at the moment is really, I have attended the 4 meetings across the province that I consider in the rural area. This is my 4th. I've been in Alberton and Surrey and Ellerslie. See, I didn't say those words again. And now O'Leary. So some of the things that I've noticed, and I'm trying to be a little bit on the constructive criticism. I know I can be often regarded as a pessimist, but I kind of describe pessimists or optimists with experience. So I've seen some of these plans and things in the past, and oftentimes there's various complications. They don't come to fruition. So that concerns me a little bit about a lot of this stuff, because a lot of it is to be worked out. But the initial idea from Health PEI about this whole thing of realignment was to unplug, I call it in simple terms, the build up and back up of beds in our 2 major hospitals. And I think you've clearly demonstrated that at all our 4 meetings, that situation exists. There is no doubt in my mind. The number varies from meeting to meeting. I think you'll admit that too, but Mr. Curry and some people, myself included, we all work without notes sometimes, and I understand that too. I don't deny that there's that kind of a problem. But what I do see is some differences from meeting to meeting, especially around the word of acute care. My understanding when we started was this thing was supposed to be really true acute care, like the sickest of the sick. But I go to Surrey, I hear the word sub-acute. And to me, I'm just a little nervous that it might be, and excuse the word, devious way to try and keep the community quiet because they think they'll be able to use the hospital close to the way that they're using it now. And the same exists here in O'Leary. If those beds, and you have way more beds that are plugged, and no doubt there is, whatever that number is, well, as soon as there's a bed comes open in O'Leary that's supposed to be this way one time or the other, when it gets filled with the extended care, then is that gone for O'Leary? Does that mean that the O'Leary beds that they would have for respite and palliative and restorative, are they reserved and protected? Because I understand there's also going to be alternative beds, but are they protected for O'Leary and in Surrey? And because my understanding was at your first meeting in Charlottetown, I apologize I wasn't there. I guarantee I'll be at the others, but I wasn't in the country, so I couldn't. But my understanding, there was a bit of a consultation at the desk whether the local doctors were actually going to be able to even admit to their own hospitals in Surrey and O'Leary. We know not in Tyne Valley, but anyway, there's just a little inconsistency there, and I'm just a little afraid that you're playing to each crowd where you are. That's my question. And
I think it's a fair question, but it's what we're trying to do is trying to explain, and the problem that we're getting from the questions from the crowds is they don't quite understand what we mean by acute care, and it means different things to different people. So, but what I want to try and explain in O'Leary is that Dr. Grimes has set up the system already as the house physician for the O'Leary Hospital, and people in the O'Leary area will be very familiar with this. He controls essentially who is getting into those beds based on the criteria that has been outlined and worked through with the medical staff. So he has set up essentially an extended care hospital 2 years ago, and that's the same criteria we talked to the Surrey physicians about, and they agreed that this is something that they could work with, and they're continuing to kind of refine that criteria to fit with the community needs there. So the bottom line is that O'Leary is already where we want it to be, so that's why there's not going to be a whole lot of change there. It's not that there's any change in the definition. Is there anything more? You're looking puzzled.
No, just a follow-up to that in O'Leary. Excuse me, I'm not from here either, but I just know what I read. So there's literally no change except 7 additional beds that were built, but not staffed. But now the budgeting's in place, and they hope to be open in the foreseeable future. But all other use is the same. So was there never one patient in the last year ever put in the O'Leary Hospital that was considered acute, or are you just changing the terminology? How could it be the same if you're trying to recapture these closing acute care beds? Were they completely empty for the year, or are you just playing with names?
The O'Leary Hospital has been pretty much at full capacity for quite a while now. And when people call from Prince County Hospital and say we have somebody that needs convalescent or somebody who needs respite, they've been very accommodating to bring people. It hasn't changed. There may well be somebody who was admitted to the O'Leary Hospital. I don't know if there's any physicians here, but there may well have been somebody who deteriorated and became acute during the time and was transferred back. I'm not sure.
Okay.
But
I'm not sure. Anyway, thank you.
I'm not aware of any, but there may have been.
Can I just clarify one thing, please? Acute care is a very subjective decision.
That's correct.
There are some people who are so acute and so critical, we can't keep them in Tyne Valley, Alberton, or Surrey. They have to go directly to Prince County Hospital and Queenie Hospital.
Correct.
The most primary are the chest pains, the strokes, and people with severe respiratory problems, people with severe asthmas. Those are very acute people, and they have to go to the main hospital where we have the backup of intensive care. And none of the doctors would want to keep them in any of the rural hospitals.
Correct.
Okay. That being said, there are some patients who are acute but manageable in the rural hospitals. That is a straightforward pneumonia, or someone with a bad asthma that is manageable, or someone with a bronchitis, for instance. Those kind of people we tend to keep in the rural hospitals. Or someone with an infection in the food or an inflammation, those kind of people we keep. I have to thank O'Leary Hospital, because recently when I had acute patients, some say someone with a kidney infection and they needed to be isolated, and they don't need to be at Queenie or Summerside. O'Leary has accepted some of my acute patients. They have been coming to O'Leary, and the O'Leary doctors have been looking after them for me, and I want to thank them. The only problem is when I send them here, the O'Leary doctors tell me to do all the history physical and dictate it, and so that when I send them here, all the work is done, and it's gratuitous work.
It's called collaboration.
Collaboration, but it's gratuitous work for me because I'm not paid for that. Okay?
Thank you.
Yeah.
Thank you, Dr.
So that's part of the problem.
So
that
that's
we ran
part of
into.
the problem. Now,
Yeah.
there are some simple people with simple pneumonia. I will go back again to the lady that was 4 times into Prince County Hospital. When we had our ER open or something like that, she would come straight to us, we would admit her, and we would look after her. She actually ended up in Tyne Valley Hospital because she was a straightforward pneumonia that should have not stayed in Prince County Hospital. She could have been treated in O'Leary, in Alberton, in Tyne Valley. So those kind of people we can look after. But in Tyne Valley, we will not be allowed to practice in our scope of practice.
I'm cutting in just for a minute. My name is Natasha Dunn, and I'm from Alberton. And I'd like to recognize the efforts of the committee who worked so hard to save their hospital here in O'Leary. You fought so hard and rallied for health care in your own community. You guys did this. That being said, and for what? The government didn't listen to their concerns back then. Does anyone here have déjà vu? This has been going on for a while. I have a concern about EMS as a big private company. You do great work. We're not talking about your skills, but it's a private company. And my concern as a citizen is that you're privatizing healthcare. Because now you've got how many beds are being put into the private system. My understanding is that if you're in a government manor, they won't liquidate your assets, right? Does it make a difference if you're in a private care home? No, not Phillips. So if someone is in a private, in Andrews Lodge, they're not going to have their assets liquidated.
Obviously, if they're in a public manner, their assets are protected, and if they're in the private sector, it's identical. It's the same.
Is it? Okay.
There's no difference.
Okay, thank you.
In respect to your question on the ground ambulance fleet, that was an agreement that was signed, I believe, in 2006. Certainly, and as I stated, I've got tremendous confidence in our ground ambulance, Island EMS. They're a highly skilled, trained, world-class group of professionals. But I do want to acknowledge that at that time, back in 2006, the government of the day signed a 10-year contract. I basically have met with the ownership of Island EMS, and they're obviously negotiating. They're a private company. But I refuse to lock in another 10-year agreement based on the Auditor General's report, which has raised concerns. So as Minister responsible for that area, we've made it very clear and working very closely. Health PEI is working on their work plan to follow up on the recommendations from the Auditor General. And certainly when the Auditor General's report is completed, we'll continue. We've extended the contract by 1 year and 1 year only. So until we get further understanding, so it's no different than negotiating a contract with anybody. There has to be clear understanding from government's part. This is public money, and we have to make sure that it's used and we get good value for dollar. And I have tremendous confidence, but that's part of the update from the contract perspective. Thank you.
Carol, the tall names man's name is Gordon Coffin. So I'm actually from Wes's district, and but why I'm here tonight is I'm the president of the Prince County Hospital Foundation. So that's the role. I've been on the executive of the foundation for probably longer than your government's been in power. So, And I want to speak to just a couple of quick points. And one of them is to issue a challenge. As on the executive, I met with Minister Curry, and then Minister Carolyn Bertram, and then again with Minister Curry, and with Health PEI on 2 occasions, most recently just over a week ago. And we have been asking for a long-term plan, okay, for health care, particularly the Prince County Hospital, because we're the Prince County Hospital Foundation. Our role is to raise money for priority medical equipment, okay? It's just a challenge to go out there and do that. Our goal this year is $1.3 million to put equipment in that hospital. And that is equipment that I necessarily don't even understand what it does. My role is to go out and do the PR work with the community, support the community, and part of that reason is why I'm up here tonight and went to Ellerslie the other night, and someone else from the Hospital Foundation was here to the other meetings up west to hear what has been happening to the other foundations in O'Leary and all the rest. And it was pretty scary when I heard Bill say that there's a whole bunch of foundations that did a vital role in the day don't even exist anymore. And we certainly don't hope that ever happens. Or different support groups and that, okay? But that does happen if we're not vigilant. But I have asked different times, please give us a long-term goal. We've asked the Medical Society to give us a long-term goal, and they have come back with one. And they can tell us that in 2014, 2015, 2016, here's what we need. Now, this year, they adjusted it. That always happens. But they had a long-term goal. I've heard it from a whole bunch of people in the room tonight. Give us a long-term goal. Give us a plan. This whole meeting, these series of meetings might have been totally different if we were working around a long-term plan and you come out with something that says, here's what we need to do. Okay, and I think so. Again, as I say, that challenge to do it, we need it because we saw it just a couple of months ago that we were in front of Health PEI, we were in front of Minister Curry and his deputy to say, please don't take away acute surgical services. Okay, and then you know this new announcement. It comes down to the fact that all of a sudden now we're one of the 2 pillars. Big change in 4 months, and I don't see it in the plan anywhere. Huh?
I've always stated that.
Well,
in every meeting I've been in, I've stated that.
Yeah.
The PCH is a vital, integral part, a 24/7, fully staffed facility, and I've made that very clear. I don't know what meetings that you were at that you didn't hear me say that, but I was very clear.
You were very clear.
I've also made it very clear that the Prince County Hospital today provides 32% of all surgeries east of Summerside. So it's not a community Summerside hospital, it's not a Western Region hospital, it's a provincial facility that Islanders are using from tip to tip.
Thank you, Minister. And again, I issue that challenge to you to come out with a long-term plan for us. Okay? Thank you.
So just to be clear,
Going to be brief.
Sorry, I just want to finish up with Gordon, but just to be clear, Gordon, are you looking for a long-term plan for hospitals or for capital equipment? For the hospital. Okay. Yeah. Yeah. Okay. Yeah.
We're going out and asking somebody for a $1,000 check or a $100,000 check.
Yeah.
And
Yeah.
they come back and say, what's these meetings about? What's that
Yeah.
about? Is that hospital going to be around? We're getting it.
Yeah.
We're getting that feedback.
Yeah. No, it's a fair question. So it's just we're taking some notes about some of the things we're going to get back to people about. But I just want to clarify, long-term is a difficult thing in healthcare because technology changes all the time. Medication changes and means different surgeries are no longer required.
Can always be adjusted.
So, yeah, you're right. So we can set a 10-year timeline, but we're going to have to adjust it every 3 years, and that's part of why the reason we do a strategic plan.
And as Minister Curry said, a huge amount of the expenditure is out of province medical care.
Yeah.
I've put that challenge out today. We're prepared, as the Prince County Hospital Foundation, go out and raise the funds if you can identify an area that can be, Prince County Hospital can become the center of excellence to do that. Okay?
Well,
and if it means taking those people back
I'll give you
to
one
PEI
now.
or whatever.
We're looking at repatriating colorectal surgery into the province now that we have 7 surgeons. So there's one that we're working on.
That's looking at a plan. Thank you.
Yeah.
Yeah, thanks, Gordon. And certainly I appreciate your question. Certainly I've had the opportunity since 2007 to see the work of Prince County Hospital Foundation. They do tremendous work. And certainly we're going through a situation right now where I recently, a number of months back, met with the fundraisers and foundation at Western. We've been in conversations with the MLA and the EVA in respect to their foundation goals, obviously the PCH. So certainly from an organization perspective, Health PEI and government really has to have a very clear plan in respect to what government's role is, and certainly, but tying into your question, it's a good question, and certainly what we want to do is we want to make sure, and it's a fair question, if for the foundations who are volunteers are out fundraising, they need to be able to respond to the questions that you get, because at the end of the day, foundations or service delivery, it's all about the quality of care across the province. So certainly appreciate the question, and certainly we do have a strategic plan that will be presented to the Legislative Assembly here before closure. So that's another positive step. So we'll continue to work towards that with the foundation. So thanks.
Question.
Thank you. My name is Robert Noy, and I'm from Tyne Valley. Just a couple of maybe questions for the recruiter. Over the years, we've certainly dealt with the hospital recruitment. Sometimes we were successful and shot down after having a doctor saying he would come, then the College of Physicians type thing. But then the Medical Society. However, with all those new changes now in O'Leary, like the rural areas, with doctors, or I better not state this until I ask the question, doctors in our area, O'Leary, where are they, if they have someone goes to them and they're sick, where is their referral hospital? Is it Summerside? Is it Alberton? Who's going to look after your patients?
So you're saying if a patient is sick in O'Leary, where's the referral hospital? It depends on what they're sick. If they have an orthopedic problem, it's in Charlottetown. If they have a general surgery problem, it's in Summerside.
Okay, okay. No, and it doesn't have to be surgical either. People have sicknesses that are acute that don't have to be
internal
surgery.
medicine, pediatrics, obstetrics are all in Summerside. Yeah.
Okay, so who do they have admitting privileges at those hospitals?
The specialists?
No, your family physician.
Family physicians in Summerside have admitting privileges?
Tyne Valley, O'Leary.
No.
Wherever. They have no admitting privileges.
No, because if you have admitting privileges, you have to look after the patient.
Well,
so they'd have
exactly.
to drive. You want them to drive from O'Leary to Summerside every day to see patients?
Well, now, if a doctor so chooses.
If they so choose, they can do it, yes?
Yeah.
They can.
Okay, so they do have admitting privileges?
No, they can apply for admitting privileges and do it. If they choose to look after the patients there, they can, yes.
Okay, so so if they get, okay, I don't have a doctor that's going to look after me in Summerside, but yet I'm sick, so I go to emergency type thing, okay?
Yeah.
After seeing my doctor, and he or she says, you know, you're going to have to go to Prince County, but I don't have admitting privileges, so good luck to you.
No, they would refer you to the appropriate specialist, who would then either look after you or the hospitalist physician in Summerside would look after you.
So, okay, so what you're saying, the only way I can get into Prince County is if I have to see a specialist?
Or a hospitalist.
Or a hospitalist?
Yeah.
Okay, so they refer me.
Mm-hmm.
What is a hospitalist? Is that a doctor?
We have physicians that are hired to look after patients who don't have a family doctor in the Summerside Hospital.
Okay.
So that's their job.
Are they on 24-hour type thing?
Yeah.
They are? Okay.
Yeah.
Okay, that's fine. So there is hope then that we might get into a hospital.
Very much so.
Okay.
I hope if somebody's sick, they want to be admitted. That's correct.
Exactly. We want to be admitted.
Yeah.
Okay.
That's everybody's wish.
All right. I said it wasn't going to be very long. One other quick question. Those meetings, are they all recorded? Is everything taped at those meetings?
Which meetings?
Those meetings we're having here now. Are all the conversations being taped?
Not that I know of, but the CBC was here a little while ago. They probably did tape something, but we're not taped.
No. Your sound system set up. Are all the...
No.
They're not?
No.
You're sure of that?
Are they being taped? I'm not aware they're being taped.
Well, you have a sound system man here?
We do, yeah.
Is he recording them? Is he recording them?
Oh, there's your answer then.
Yes, he is.
Yes, he is. Okay. Yep.
Okay. So, is it the intent of government then to sit down and analyze all the results of those meetings, or are those tapes available to anybody who attends the meetings? Can we get a copy of the tape?
I'm sure that you can take them home tonight if you really wanted them. I mean, it doesn't matter. I don't know. You'll have to. We can make arrangements if you want a copy of the tape.
Thank you very much. I'd appreciate that. And you probably have a list for more people wanting them. Thank you.
Thank you very much. Thank you.
I just want to thank the people for coming, and I would request that we have a consultation in this area with the people. We started a good thing with the focus group. We had an excellent group sitting around the table of people from all different things, from public health to whatever, and us former healthcare people. And we'd like to request that you keep these focus groups going as a consultation group. Not this forum. No, I mean sit down at a table and let us make some decisions, or at least request some decisions. And I want to thank Arlene for coming too. Arlene, we're with your hospital. We will be attending the meeting in Summerside. Thank you.
Minister? Yep.
What's the date? Yeah, the meeting in Summerside was scheduled for Saturday morning. I'm going to be at a province, and I want to. So the meeting's been, I think, rescheduled for May 6th at the At the Loyalist. So, anyways, I know a lot of people are leaving. I just want to say before people get out, thank you very much for coming. Thank you for your questions and taking the time. Thank you very much.